Okay. All right. Good afternoon. Calling this performance oversight hearing to order. I'm at-large council member Christina Henderson, chair of the Committee on Health. Today is Wednesday, February 5th, 2025. The time is 2:07. Apologies for the delay. We had some rooming challenges. Today marks part two for the performance oversight hearing for DC Department of Behavioral Health. We heard from the public witnesses on Monday, and today we'll hear from Dr. Barbara Bazaron, who is the director of the department, as well as her team. The Department of Behavioral Health, or DBH, provides prevention, intervention, and treatment services and supports for children, youth, and adults with mental and/or substance use disorders, including emergency psychiatric care and community-based outpatient residential services. DBH serves eligible adults, children, and youth along with their families through a network of community-based providers and government services. DBH manages the district's school-based behavioral health program and operates St. Elizabeth's Hospital, the district's inpatient psychiatric facility. DBH serves the district residents based on the belief that they can recover from mental and substance abuse disorders and live happy, healthy, and successful lives. On Monday, we heard from nearly 100 public witnesses, including students, community-based providers and contractors, childcare center operators, interested community members, and advocates. They spoke on a range of issues, including the grant administration and payment issues, the opioid crisis, the urgent need for more clinicians and behavioral health staff, particularly for pediatric, youth stress and trauma, and as well as the need for increased accessibility to and of DBH programs and services. I don't see any of my colleagues here, but there is a full house in the Wilson building today, so I'm sure some will stop by at some point, and we'll certainly turn to them when they get here. Dr. Bazaran, but you can go ahead and get started. But before you begin, of course, I need to swear you in for you and any of your members of your team who may speak today. If you could raise your right hand. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia in this committee is the truth, the whole truth, and nothing but the truth?
I do.
Great. When you're ready.
Okay. Good afternoon, Chair Henderson, committee members, and council staff. I'm Dr. Barbara J. Bazaran, Director of the Department of Behavioral Health. With me today are Dr. Megan Sullivan, Deputy Director of Child and Adolescent Family Services, and Dr. Sean Moise, Deputy Director of Adult Services, and Michael Neff, Chief Operating Officer. Thank you for the opportunity to discuss DBH's performance in FY 2024 and fiscal year 2025 to date. My complete testimony has been submitted for the record. Under the leadership of Mayor Bowser, DBH supports healthier, stronger communities by working to prevent the onset of mental health and substance use disorders and providing a range of community-based treatment services and recovery supports. DBH also provides crisis services, operates adult and child urgent care clinics, and manages St. Elizabeth's Hospital, the district's psychiatric inpatient hospital. Through Mayor Bowser's continued investment and support by the council, DBH is transforming the public behavioral health care system to provide whole person, culturally competent care for those who rely on it while working to advance health equity and address the behavioral health needs of all residents. A few days ago, our city and our country experienced a heartbreaking tragedy when a plane and helicopter collided over the Potomac with 67 people on board. Our love and prayers are with the families and loved ones. It's common for people to feel stress after a tragic event, and you don't have to be directly impacted to experience emotional distress. Anyone feeling the effects of this tragedy can speak to a crisis counselor anytime by phone or in person. You do not have to be enrolled in DBH services to speak with a counselor. Crisis counselors offer free immediate counseling, share healthy coping tips, and refer for follow-up. The number to call is 202-481-3806. Call for yourself or someone else. I would now like to share our progress in transforming the behavioral health system with a whole person care framework and briefly update the committee on key strategic initiatives, which we reported on in detail in our responses to the committee's pre-hearing questions. I want to thank the committee staff for working collaboratively with my team throughout this process. In FY24, about 45,500 residents received treatment and support services, which stayed steady with FY23 utilization when we saw a 42% increase over pre-pandemic numbers. Services were delivered in a hybrid model with nearly half through telehealth. Last fiscal year, we also saw a 12% increase in utilization of substance use disorder services after a decline during the pandemic years. We're getting closer to pre-pandemic levels. It is encouraging that about 3,084 individuals in FY24 received medication-assisted treatment for opioid use disorders from DBH providers and in primary care settings. Though the transition of the provider network into managed care remains paused, DBH has continued to adopt the whole person care framework. We are transforming how services will be delivered and measured along with changing business processes to improve health outcomes through better integrated care. We are working with providers to improve overall performance and target improvements in services that support our most vulnerable residents. To briefly summarize, the foundation for whole person care is timely access to both physical and behavioral health data. We require that a provider have a certified electronic health record to capture and enable the transfer of health information. DBH worked with DHCF to obtain grant funding to support providers to implement evidence-based practices, to implement and optimize their electronic health records. In addition, we implemented evidence-based practices to improve quality of care. We targeted support to providers of substance use disorder services with extensive training and technical assistance on person-centered care and treatment planning using nationally recognized medical necessity criteria. Revenue has been added to the provider network to support financial stability. Through rate increases and new services between 20 and 23, there was an average increase of 24% in provider revenue. I'd now like to briefly talk about combating the opioid epidemic. DBH, along with its 100-plus community and government partners, is encouraged by the significant 30% decline in opioid-related deaths and 17% decline in non-fatal overdoses in the past year. This decline is coupled with an increase in the number of people in treatment, which we know is critical to sustaining recovery from this chronic illness. We often ask why the deaths have gone down. We are often asked that question. There is no one reason. Through Live Long DC, the district's plan to combat the opioid epidemic, we have implemented evidence-based practices in prevention, treatment, harm reduction, and recovery supports proven to reduce opioid use, misuse, and related overdose deaths. These strategies are supported by our federal state opioid response grant and the opioid abatement fund. This year, we will award about 100 grants to community partners. We've made it easier to access treatment through multiple access points, including community-based providers, medication-assisted treatment in primary care settings, and treatment units in DC jails. In the first 15 months of operation, the first stabilization center saw 7,666 admissions and is fulfilling its promise as a low barrier stepping stone to treatment, with 22% of the individuals linked to ongoing treatment and support. While we are grateful that the rate of overdose deaths is declining, we're keeping our foot on the gas by doubling down on what is working and with new initiatives that target populations where the data tells us there is an uptick in risk, including young people and Hispanic residents. DBH provides crisis services on the telephone, in person, in the home, school, or in a community location. Most people who call for crisis support get the help they need in the moment on the telephone as crisis counselors listen, help to solve problems, offer healthy coping strategies, and refer to ongoing care when needed. The Access Helpline, which is our 988 call center, is now fully staffed with the hiring of additional crisis counselors. We also added a chat and text function last September, which expands access and supports people who prefer this method of communication. In FY 2024, DBH received 10,200 calls to 988, a slight increase from the 9,700 calls in FY 23. DBH staff are co-located at the Office of Unified Communication to support the diversion of 911 mental health related calls to DBH instead of an automatic law enforcement response. To be clear, our MPD partners have a crucial role to play in assuring the safety of the individuals, the community, and the responders when necessary. Mayor Bowser has directed that every officer be trained to recognize mental health indicators and to de-escalate those situations confidently and competently when they do respond. Working with MPD, 97% of active officers have been trained either as crisis intervention officers or in mental health first aid. I'd now like to talk briefly about prevention in early childhood and school-based services. Studies have identified the worsening trend in youth mental health, including children who have never previously displayed symptoms of a behavioral health disorder. DBH is focusing on mental health screening, evidence-based practices that support trauma care, and strengthening parent engagement and parenting skills as critical ingredients to address youth mental health. The District of Columbia is the only jurisdiction in the country where elected leaders have prioritized the behavioral health of young people by funding at least one licensed mental health clinician in every public school, according to our research. School-based clinicians train students in anger management, conflict resolution, and building social and emotional skills to help them problem solve, cope with grief and loss, reduce stress, and manage their emotions, which promotes healthy decision-making. We continue to face a shortage of licensed clinicians, which has delayed the expansion to all schools. Prior to the pandemic, about 90% of public schools had a clinician on site, either from a partner, community-based organization, or DBH, or both in some schools. Today, that number has dropped to about 60%. To help address the shortages of licensed mental health professionals, we have initiated 2 pilots, which we can talk about during our discussion. With Mayor Bowser's direction and investments and the support of council, we are transforming behavioral health care in the district. Our vision is that all residents have the opportunity to get the support they need to live healthier, longer lives. I want to conclude my testimony by expressing my appreciation for certified peer specialists, leaders of consumer and recovery groups, and peer-led centers who model our conviction that treatment works and recovery is possible for everyone. Thank you, Chairperson Henderson, for your commitment to the health and well-being of all district residents. I look forward to our continued work together. I am ready with my team to answer any questions.
Thank you, Dr. Bazaran. While you were speaking, we've been joined by Councilmember Brianna Doe from Ward 1, who's a member of this committee. Councilmember Brianna Doe, did you have an opening statement that you wanted? Sure, go ahead.
Thank you very much. And thank you, Dr. Bazaran, for your testimony. There have been encouraging developments in the past year. We've continued to see success from dedicated outreach workers focused on Columbia Heights, and I've been hearing astounding data on overdose reductions from our partners working in the 600 block of T Street. My committee was able to transfer funds last year to continue this program that's a critical part of a comprehensive approach for people living with substance use disorder. And I'm eager to hear how we can continue to expand this model to other areas of the city and make it a permanent fixture for DBH. I've been encouraged with the progress on the Columbia Heights Sobering Center and how DBH has worked with my office and the ANC to provide opportunities for community engagement. And my staff even got an opportunity to tour the K Street Center and see the important work being done there. Opening the Stabilization Center will be a critical step towards addressing longstanding substance use disorder needs in our community by expanding access to treatment and care. I am concerned by some of the updates related to behavioral health care for children who are most vulnerable members of our community. The Child and Adolescent Mobile Psychiatric Service, or CHAMPS, was designed to prevent inpatient hospitalizations and other disruptions for children using interventions tailored to children and their families. But there's been an uptick in behavioral hospitalizations for children. So I'm looking forward to discussing these topics today. And I thank you for your testimony, and I look forward to a couple of rounds of questions. Thank you, Madam Chair.
Thank you. I've also been told that we've been joined by Councilmember Zachary Parker from Ward 5 online. Councilmember Parker, did you have an opening statement?
I'm going to bypass the statement so we can jump into questions.
Okay, thank you, Councilmember Parker. All right, so we'll be on 10-minute rounds. Like I said, there's a packed house in the Wilson Building today, so let's see how many of the colleagues join us. Dr. Bazaran, I want to start talking about staffing. I understand that the agency has experienced some staffing challenges in the past year, and I want to better understand, is it a agency push, or are there vacancies that just have not been filled? So let's start. At least in my knowledge, I'm not aware of any major reduction in force that took place with the agency in the past year. Is that correct?
That's correct.
Okay. So then any of the staff reductions per se would be from a vacancy issue.
Correct. Yes, I think that what we are faced with is the workforce shortage. Essentially, we do have some hard to fill positions that include psychologists for specifically our school-based behavioral health, LICSWs, licensed social workers, as well as nurses. And we do post positions, and positions are open, but I think we are experiencing the same thing that's happening around the country.
Okay, so let's separate out what's happening at St. Elizabeth's, which I think is we heard from some staff there, so I think that's a fairly unique because we're talking about specific medical professionals. But in terms of DBH Maine, my understanding is that your school-based mental health clinicians are not actually on your FTE roster because they are part of contracted out in some cases, correct?
They are, but we also do have school-based behavioral health clinicians on our roster.
Okay, so what's your
Mhm.
vacancy rate right
Um,
now?
How many are vacant?
Not school-based mental health. I'm talking about for the whole agency.
In terms of the entire agency, I
Yes.
can get that for you momentarily. Just give me a moment. May I come back to that?
Sure.
Get that for you.
In particular, we heard some testimony specifically about your claims department. And so I'm specifically interested in the staffing there and what challenges might be.
Okay, our vacancy rate at St. Elizabeth's Hospital is 11%. For the Behavioral Health Authority, it's 23%.
Okay. What's the long-term plan to address some of these issues? 23% is high.
Yeah, and I think here again, a lot of them are hard to fill positions, and we continue to do a number of things. We continue to certainly post and do recruiting efforts, and in the instances in which we had additional funds, we were also able to provide some incentives for people to come.
Okay. You guys go through DCHR?
I'm sorry?
You go through DCHR for your hiring?
No, we have our own, we have our own independent hiring authority.
Okay. Is, DCHR's website is not the easiest to sort
Yeah,
of
it's
navigate.
Yeah.
So you have your own. I'm putting this out there. There's some individuals in our region who are
Mhm.
looking for jobs. So we just need to make what
Happy
some
to-
are aware.
Happy to hire them.
How many staff do you currently have in the claims department?
In the,
Claims?
Michael?
Thank you. Currently, we have 4 people in the claims area. I would like to differentiate the difference between claiming, which is submission of claim form records, HCFA 1500s, which are processed through machines,
Mhm.
and grants, which are not claims.
Correct.
All right. So on the fiscal services side of people who process and review invoices prior to submittal, we have 2 vacancies out of 7 positions. They are posted. We've had difficulty recruiting them. I think the issue there is from FY23 when we had 131 grants to review, and it's now 196, which is currently, which is a 50% increase in volume overall. So as I said, those positions are posted. We've not had a lot of luck. We're working with our HR to look at posting it on other sites within their region to see if we can recruit that way.
Okay, so in the absence of a full team, are we communicating a delay to?
Well, we actually have pulled all of the areas together at DBH that oversees the claiming or the grant management process. So that's the program areas, it's fiscal services, grants management, it's the OCFO. We've also detailed staff from other parts of the agency temporarily to backfill positions. They carry a lighter caseload so that we can keep up with volume until we can get those positions filled. I think we've done some other steps to look at. We've heard from grantees that if they could have a tool that was readily available to them, that they would be able to use, I think, for 2 of the most difficult areas, which is grant formulation and the submission of invoices, it would be helpful. So we are looking at creating videos of how you can do that are developed. We do have an agency in DC who does that now, and we're working with them to see how that's worked.
Okay, so you've pulled the teams together. So how many individuals are we talking about?
In terms of people involved end to end,
Yeah, you said you
Does-
pulled physical services, you've pulled program together, you've detailed. I'm just trying to get a better understanding of how many folks we're talking about relative to the number of grants you're managing.
Well, they aren't managing grants. Some of them are stepping in and filling in temporarily. We have detailed 2 people for the 2 positions that are empty.
Okay, so that team should be back to its core of 7. Is 7 enough?
Probably not. The thing that's important here is we can look at certain steps to shorten the process, and we have 5 steps to do that. The important thing is we are in the final steps of purchasing an electronic grant management system.
Yeah, that was gonna be my next question, because I feel like we talked about this last year.
Yes, and we went through a full RFP process and did not get a respondent that qualified. So,
For our grants management system,
correct.
what are we asking for? An
Well-
AI moon? Like,
No, we didn't. We ended up getting technical support that turned out to be a temporary staffing agency that was a respondent, and that obviously is not okay. So we are actually going to purchase a electronic grants management system where we can quickly modify it to be DBH specific. And what we're looking at is one that's already compliant with the mayor's grants process, which mirrors the federal grant process.
okay, are you not using, what's the current system that you're using right now for grants?
There isn't one. It is a manual process, and we use SharePoint as a shared site to pass documents internally.
Okay. I was under the impression that you were using a system that was similar to what DC Health had.
We will be.
Mhm.
Okay, so you
Yes.
will be, oh, you're acquiring a system that's similar to what I see.
Right,
Okay,
the Salesforce platform.
Yep.
Mhm.
And we've already purchased the platform. We now need the tool to move over to the platform,
Mhm.
which will allow us to move much more quickly to implement it. We expect to have it implemented or certainly operational for our purposes, start entering in and using it in August of this year.
August.
Mhm.
Okay. Um, all right. I don't have enough time to get off another question. I'm gonna let that marinate for a minute because I'm not freaking out, but just sort of, this is now explaining lots of things. Okay, so we've been joined by Councilmember Wendell Felder from Ward 7, Councilmember Felder. Everybody ahead of you is also part of the committee, so just sit tight, enjoy the ride. Councilmember Nadeau.
Thank you, Madam Chair. I wanted to ask some questions about the Columbia Heights Stabilization Center. Thanks again for working together with me on community engagement. I am concerned that our timeline seems to be continually shifting. Originally, we were told it would open in FY '25, then we were told early 2026, and it looks like the most recent estimate is spring 2026.
Mhm.
And I know there was some additional work that needed to be done on the structure, but can you share more about these delays and assure us the timeline won't be further delayed?
Certainly. I think a part of it has to do with the remediation of the facility. What happens is once they got in, they found that they needed additional time to really make the facility safe for us to conduct services. And that's a timeline that we don't have a lot of control over. We got to do that work because we certainly want to have a safe facility. And the latest date that I have is the one that you just shared.
Okay. Okay. Does it seem as though the remediation is following along a schedule that as expected?
It is, but in some instances, we're finding that they need more time once they get in and see what's going on in terms of, all of the environmental concerns that we've identified before for that center.
Thank you very much. I want to request that we have additional community meetings to share the final design plans, construction timeline prior to the beginning of construction, and introduce the new clinical provider once selected as well.
Absolutely.
Great.
As we've said, in our meetings, we do plan to develop an RFA and put that out. And we will certainly be talking with the community as we develop the RFA. So please, we'll be happy to join you with that on that process.
Wonderful. I know that you've created an email address where community members can reach out with feedback or questions. Is there an opportunity to publish an FAQ with answers to commonly asked questions for community reference?
Yes. Yes, there is.
Councilmember, hello. Yes, we do have a plan to do that. The FAQ questions and answers and context from the last meeting have been finalized, and we will be publishing them in the DBH website as well as the website for the stabilization center that we just implemented recently within the next week or so.
Oh, wow, great. I know that operating costs will be dependent on the final parameters of the center. But do you expect operating costs to be similar to the K Street Center?
Right now, we I can't really tell you what the final cost will be. I think that it will depend upon what happens as we put the RFA out and what we get back in terms of our needs. What we do know is we do know what the basic core services are that are required. We do know some of the time parameters like 24/7 care and so forth. And so we'll have a better sense once we get those data.
Great. Anything notable that you're considering about the Columbia Heights location that would be different than K Street at this time?
Well, yes, first of all, we do know that we need to have bilingual staff there. And so that certainly will be a part of it. The other thing that we have spent time thinking about is how to cause the least amount of disruption in terms of the ambulances going in and out and making sure that we have kind of planned for that. And the other thing is because it's in a neighborhood, we want to make sure that we have a clear feedback loop of communication. So if issues arise, we can resolve them sooner rather than later and not have to wait until there's a crisis.
That's great. I was interested to see in your pre-hearing responses, the DBH and the Department of Healthcare Finance are in the process of adding substance use disorder stabilization center services to DC's Medicaid state plan amendment. Where are you in the process, and when can we expect that to come to fruition?
We are really in the process of developing those codes, and this was something that we had planned from the very beginning. What our plan was, if we wanted to wait until we had some experience with the first stabilization center, and then based upon that, then decide, what the appropriate array of services and supports might be to support a stabilization center, because it really is, not a CPEP, a crisis psychiatric emergency program, and not an outpatient or a recovery. And so we wanted to make sure we use the data to support that.
Wonderful. Thank you very much. I appreciate that just a moment ago, you mentioned the importance of bilingual staff at the Columbia Heights location. In the Office of Human Rights FY23 Language Access Report, DBH scored a 6 out of 14. And so you can understand why I'm concerned about how that might replicate in the stabilization center. What are you doing to improve language access throughout the agency so that everybody, even if they're not bilingual, knows how to serve people who are?
Well, actually, we have addressed the issues that were in that report very forthrightly, and we have done things like ensuring that there is language access to written documents, as well as ensuring that not only the language line, but there are also live individuals who can provide translation services. Those were things that were raised, and we have moved forward with addressing them.
Wonderful to hear. Thank you so much. Language Access Act is in the Office of Human Rights in my committee, so we take that very seriously. I mentioned earlier the Community Navigators program that we've worked together on. Have all the grants for the FY25 Substance Use and Behavioral Health Services Targeted Outreach grants been issued?
Yes.
Great. As part of last year's Substance Abuse and Behavioral Health Services Targeted Outreach pilot, grantees were required to submit program reports to DBH, which you noted DBH would use to inform future work. Has DBH reviewed these reports, and what lessons have been learned from the pilot?
Yes, they do actually submit reports on a monthly basis. They are reviewed by the individual who is responsible for outreach, as well as by our chief of staff. And what we have learned and looked at is things like, how often are people there? How many people are being addressed? How many engagements are we having? How many referrals are being made, and so forth? And, you know, a part of it is, a lot of this is all about relationships and building relationships with people in the community so that we can direct them and refer them and connect them to the proper care. And so those are the kinds of things we've been looking at.
That's really exciting to hear. Is it possible that any of these reports could be released publicly or shared with the committee?
Yes, absolutely.
I'd love to see it so we can better understand too
Sure.
how the grants are
Yes,
working.
because we do collect that data.
Wonderful. I'd love to pick up on the conversation you and Chairperson Henderson were having about delays with grants. You and I, even today, have been in contact about a
Yeah.
grant payment. Yes, so thank you for personally getting involved with that. I am concerned about the payments of these critical grants between now and August, particularly given the important work the grantees are doing. So you were talking a little bit about the system you use right now. Why do we not have a system like DC Health's per year of grants?
I can't really answer why we don't have it,
Yeah.
but I can answer that we will have it.
All right. Because right now it's very much based on
It's-
human workflow.
Exactly.
Okay.
It's based on human workflow. This is why I tasked Mr. Neff with bringing together all of the people involved so that we could look at the flow, see where there are issues that need to be addressed, think about how we might be able to mechanize this process so that we can decrease the time period and not have to do it by hand, essentially.
Wonderful. I'm going to stay for just a second round, but I want to thank you for being so direct and brief with your answers so that we could get through so many questions in one 10-minute round. That is not true of everybody. Thank you, Madam Chair.
Thank you, Councilmember Nadeau. Councilmember Parker?
Yes, thank you. And it is good to see you again, Director. I'm going to jump right in with a number of questions. What steps has DBH taken to publicize 988 more broadly to residents of DC, particularly those residents in areas of the city that are seeing the greatest need?
I think that, first of all, we have utilized the national billboards, messaging that is related to 988 that has been developed by Vibrant. And we've used that to post information on bulletin boards. We've used it to push it out across social media. We have used it when we've gone to meetings to talk to people about. We've done it very widely to our provider community and so forth.
I appreciate that. I will say transparently, I have not noticed much advertisement either on social media or throughout Ward 5. So I welcome partnering with the agency and seeing how we can get the word out more to residents.
Thank you.
Do you still have 7 vacancies? I noted that in your pre-hearing responses.
7 vacancies in?
For that team that manages the 988 line.
Our access helpline is fully staffed, which includes the 988 line. We do have vacancies in our community response team.
Got it. So maybe I confused those two. My apologies. I noticed that there was an uptick in the number of abandoned calls at the end of last year. What might be the reason for this?
I think in terms of the abandoned calls, Here again, a part of it is that sometimes when we did have vacancies, we had fewer staff answering the phone and some of those calls were longer. And so I think that, that's one of the.
And would you, you only provided abandoned call numbers through December.
Mhm.
Where about do we stand today or so far in fiscal
I can
year
get that
25?
information for you and send it to you.
Okay. I mean, it goes without saying, it was alarming to see the numbers go from about 80 to 100, and now we're approaching 120. So we just want to keep an eye on that.
Okay. Mhm.
Last year, I remember in the hearing, there was a complaint about the quality of service for individuals that called into 988 or other access lines at DBH, namely that whereas in years past, you may have provided a direct service or connected individuals directly with care, you had transitioned to just merely giving out information and leaving it to the individual to follow up.
Mhm.
Have you taken any action on that,
Yeah.
given that that was feedback provided last year?
Yes, certainly. That's through the Access Helpline, and that had to do with a um, a new process that was put in place as a result of the transition to managed care. We did not know at that point, it was going to pause, and we thought that a lot of services, some services were going to be transferred to the Department of Healthcare Finance. We have now ensured that Access Helpline, and I have personally gone and talked to them, they do and will provide the same kind of services that they always provided, which includes connecting people to care, as well as doing the administrative tasks also related uh, to the provider community. It is now fully staffed also.
Dr. Bazarn, I think we've lost Councilmember Parker.
Oh, okay.
He dropped off for a minute. Oh, we'll give it a minute and see if he is able. Ashley, if you could pause the clock, let's see if he's able to rejoin.
Mhm. Councilmember,
Yep.
if I might, I did get some more updated information on the vacancy rate, if I might share that with you.
Sure.
And so what I found is that this year we have also improved on some of those rates. This year it is 13%, which is really good. And then the attrition rate of 5% for government is what we're seeing, which is about normally what we see in terms of people leaving the jobs.
Okay. All right. I've taken note of how much time Councilmember Parker had left. And so if he rejoins, we'll certainly give him back that time. Councilmember Felder.
Good afternoon, and thank you, Madam Chairperson Henderson, for hosting today's oversight hearing. I also want to thank Dr. Bazran and your team at the Department of Behavioral Health for their ongoing efforts to support residents facing mental health challenges and substance use disorders. These are tough issues, but from what we have heard from public witnesses, we've made important progress in expanding services and increasing access to care. With that, there's still more work that needs to be done, especially in areas like Ward 7, where too many residents are struggling with untreated mental health conditions and substance abuse is far too common. For example, Ward 7 is disproportionately impacted by the opioid crisis, with more residents overdosing and losing their lives than nearly anywhere else in the city. This means that we need to double down on treatment, harm reduction, and prevention strategies and make sure that the areas hit the hardest have the resources it needs. We also have a responsibility to educate our youth, particularly around substance use. While recreational marijuana is legal for adults, we must ensure young people understand the risk and have the knowledge to make informed decisions about their health and future. While our city has strong behavioral health resources, we must continue to strengthen and expand them to better meet the needs of our community. I look forward to working together to build a system that ensures every resident has access to quality mental health and substance use services when and where they need them. Thank you for allowing me to provide opening remarks. And I guess with that, I'll jump right into my questions. I heard my council colleagues previously ask you questions as it relates to personnel and budget. So I just have a follow-up question. Out of all the agencies, you all have seen an increase in your budget by 1.7% from FY 2024 compared to FY 2025. However, during the same time period, you have experienced a reduction in FTEs. How, if all, has this reduction in staff impacted your operations?
I think that and correct me if I'm wrong, we've had only minimal reductions in FTEs, during this year. Is that correct? Mhm. And so I don't know that as much as the workforce challenges are what have really impacted our budget. I mean, our ability to provide services.
Copy.
It's the vacancies that really have done it.
While your funding has seen an increase over the last 3 years, what are the core areas that you believe need additional funding to fulfill your mission?
Well, I think that obviously one of the things that has been raised over time, both in hearings this year as well as last year, has to do with the implementation of school-based behavioral health. I think you probably heard a number of providers and other folks speak to that issue. And regarding the school-based behavioral health program implementation and funding, due to the budgetary implications, the mayor's budget team is currently really reviewing that. And once addressed, we will see how we move forward.
What strategies do you have in place to address the major corridors such as Minnesota Avenue, for example, where overdoses are prevalent?
Well, I think that one of the things that we've done is we have outreach teams who are there. Our community response team is there on a regular basis. We also, so that we can really build those relationships, and the goal really is to make those connections with individuals there so that we can work with them around getting care. The other thing is we also distribute naloxone. We use fentanyl test strips and a whole variety of harm reduction services and supports to keep people alive. So that's one of the things that's critical.
Thank you, Director. I also see that in FY 2025, there were a total of 36 grievances filed. What is your agency doing to correct those grievances?
We do have a process for addressing grievances. When a grievance come, we investigate the grievance, we follow up, and reach some resolution.
Could you tell me a little bit more about your evidence-based supportive employment program? How long is the employment term?
I will begin, and then I will have Dr. Moise talk a little bit more in detail around supported employment. We actually have done supported employment now for, oh my God, I guess many years, almost 20 years. And the goal there is to provide support for individuals with mental health and now with substance use disorders, and that was a recent addition, so that we can help them identify job opportunities and remain in the job. That's the thing. So provide them with those supports they need so that they can be successful in the job. We work very closely with RSA. then they actually provide incentives for our providers so that if certain benchmarks and goals are met, they get additional dollars as they're providing that support. So it's been a very successful program. It's been a very successful partnership. And I was really happy when we were able to add substance use disorders to that. It is a billable service by Medicaid. I don't know if you need anything.
What evidence of success do you have to demonstrate that the evidence-based supporting employment program is working?
You want to respond to that?
Thank you, council member. We have about, I believe, I'll have to get back to you to confirm the number. I don't have it in front of me, but about 550 consumers participating in this program. We have good partnerships with employers as well as other agencies. And I think the evidence is primarily based on how long people stay employed and how successful they are once they are placed in those positions. So I could get you some numbers about tenure, but everyone involved has reported that that's a very successful program, and we're very proud of it.
Thank you. I see that you all have a partnership with the Deputy Mayor's Office for Planning and Economic Development to support behavioral needs for residents living in new community developments. One of those new community developments is Lincoln Heights and Richardson Dwelling. I would like to know, how's the program going? Do you know how many residents participated in the program? And how you can provide information on the number of participants by each community?
Could you describe a little bit more about the nature of the supporters that you're talking about in terms of to the residents?
Based on the,
Grant out.
I'm sorry.
Is it the new grant effort that you're talking about?
So the Deputy Mayor's Office, which oversees the new communities projects, for example, Berry Farms, Richardson Dwelling, Lincoln Heights, Park Morton, these sites work closely with community-based organizations and social service programs. So within the information that you provided, you said that you have a partnership with the Deputy Mayor's Office of Planning and Economic Development that supports mental, or rather supports behavioral needs for those residents. So I wanted to know, how is that going?
But I think that's where we have our co-located staff.
Okay, well, we have several programs and staff initiatives that are focused on people in certain neighborhoods and targeted residences that suffer from behavioral health conditions that need support and service. We have our integrated intensive care coordination division. We have a new program and grant from SAMHSA, which is more focused on getting people into housing for the first time and maintaining their housing. And we also provide support to folks in various, locations, irrespective of their housing, kind of whether in a voucher program or not, who may need assistance and support. So I'd have to get more information about the needs in that particular building and how we've been engaged in the past. But a big focus of ours through several different pathways is to identify folks in the community, whether in a DBH housing voucher program or not, who need assistance, and try to get them connected to care to keep their housing and to get the services they need.
I'll save my remainder questions for the next round.
Thank you. Okay, we've been rejoined by Councilmember Parker. We clocked you at 5 minutes and 45 seconds. So I'm gonna be generous and give you 6. So you can finish your first round, and then we've been joined by Councilmember Matt from Ward 3. Like I said, very popular today, Dr. Bazran.
Yeah, it's a party. Thank you for that extra minute. I was going to say Dr. Bazran took my time. Director, I wanted to come back to you. It is my understanding that CFSA, the Child Family Services Agency, Warm Line team has moved into office space with DBH, and there is coordination between your two agencies to help manage their Warm Line. Can you describe the scope of this partnership?
The source of the partnership, first of all, is I met with the interim director Trice who indicated that they needed to move out of OUC because they had limited space there. And would we be able certainly to accommodate them in space within our building at 64 New York Avenue? We saw this as a wonderful potential collaboration because, as you know, we also will get 211 calls, and we thought that having everybody in the same building, we might be able to better integrate that particular service and not have two different agencies doing the same service. So they will be down in our building in 64 New York Avenue. And we really hope to launch that on 211, which is February 11th, which is next week.
That is helpful. Quick follow-up. Is there any staffing collaboration between your two agencies or training partnerships? Or is it merely
Absolutely.
office
Absolutely.
space?
Absolutely. We do want to certainly train all of our team members who are working in 211, so we have better synergy between the two agencies, and that is also in the plan right now.
Got it. That is helpful. DBH saw a 42% increase over pre-pandemic numbers in residents receiving treatment and support services in fiscal year 23. And this increase has remained steady through the last year. What steps did DBH take to meet this increased demand for services over the past year? And are there any challenges that we should be aware of?
I think that, are you talking about both mental health and substance use services, sir? Okay.
Yes.
Yes, one of the things that we have done is we've really expanded the continuum of care because we did find that there were some services that were needed to fill out the service continuum, which has been very useful, and that's on both the youth side as well as on the residential side. We also expanded the number of environmental stability residences that operate. So when people step down and they need housing in the community, when they're impacted by substance use disorders, they have a place to go that's clean and safe. And then, and so I think that that's really what we've done. We've expanded the array of services. And by the way, we have also expanded the number of evidence-based practices that are available in partnership with DHCF. We have
Okay,
also.
and I'm going to jump in because the clock is
Okay.
ticking. Sorry about that, Director.
Okay, sorry. Yeah.
DBH listed metrics for youth who received a follow-up service within 30 days after emergency department visits for either
Right.
alcohol or drug use. I believe that number was at 54%, and youth who received a clinical follow-up within 30 days of discharge for psychiatric hospitalization at 83%. Well, I understand that these are new metrics and a baseline will be established, I believe, this year. How are we defining a follow-up service?
Dr. Sullivan will respond.
Thanks so much for your question. You are absolutely correct. These are our new HEDIS measures that we're measuring. And so I think what we're looking at, a follow-up will be, it's a clinical billable service. So again, it can vary, but what we want to make sure is that once they're leaving an inpatient psychiatric, that they're connected with resources, an agency, and then that follow-up appointment actually happens. As you know, sometimes we make those appointments and for lots of different reasons, they don't make the appointment. So what we're making sure is that they make that initial appointment so that they can get engaged in services in the community.
Thank you. In my last minute, Director, I'm going to ask for just rapid fire responses. What progress, if any, has been made to bring an additional treatment facility online targeting wards 5, 7, and/or 8?
A treatment facility for?
Like a drug or alcohol treatment facility in wards 5, 7, or 8.
I don't know that any additional facilities
So
in
I'm-
5, 7, or 8. However, one of the things we have done is we have put out and I think we're very close to finalizing an RFA for a residential facility for youth.
That's great. And that is a gap. And so I
Mhm.
do acknowledge that. I just will use my last 20 seconds to also say we need sobering centers in Ward 1 and in other parts of the city. But it is a shame that where we're seeing the highest deaths and need for services, we don't have a plan to address them. So I do hope that that will be on the agenda for the year to come. Thank you, Director.
Mhm. Yeah, thank you.
Thank you, Councilmember Parker. Councilmember Freeman.
Thank you very much, Chairperson Henderson. Good to see you, Dr. Bazran. And thank you for, the critically important and difficult work that you all are doing. We are still in the midst of what I think of as a mental health crisis, and so you are our front line. As our front line, you can expect to be pushed very much by us because of the critical role that you play. We have in Ward 3 in the last months, we've had episodes where we've lost 3 children, or 4 children actually, in the last year, in circumstances that are tragic and in some cases look like neglect. I don't know whether you've seen the news about this, but for example, there was something in the press just the other day about the young woman who passed away and then her baby died sometime after that.
Mhm.
And I don't want to make a direct line to, what all of the circumstances around that are or may have been, but it raises in lots of people's minds, what are we doing to make sure we're supporting people with critical needs? And what are we doing in the process of assessing whether folks are ready for independent living or need some other sort of housing support at the stage that they're at? And I'm curious, how does it work in your agency when there is an assessment? You have a
Mhm.
number of tools in your toolbox,
Right.
and you have to decide which one is the most appropriate. Help me understand how you go about that, what tools you use in the assessment process.
Well, first of all, in terms of our housing process, our core service agencies are responsible for making an assessment to determine what level of housing the individual needs and can be successful in. And then to provide those supports that are needed for them. In addition to that, since you talked about someone with a baby, the other thing to note is that we also just did some extensive training around postpartum women and infants programs in partnership with SAMHSA to provide our providers with even more information about how to address the specific needs of that population of focus, which I think is important.
So I hear you saying your service providers do that upfront assessment.
They
but
do.
Do you know what tool they use? What do you do in terms of oversight
Know
of
what
that?
clinical tools they are using to make that assessment, but that's something we can certainly follow up. But that is a responsibility for the clinicians at the core service agency level.
Yeah, I mean, my experience, and it's anecdotal, is that there are folks who need more support than they're getting under the current system. And so some of that goes to how's the assessment done up front? We have different kinds of tools. So we could have folks in
Absolutely.
settings that would better serve them and would better serve the community. So I will want to be following up with you about what kinds of assessments that you use. And then
Happy to do that.
talk to me about what kinds of supports you require your service providers to provide in for example, a permanent supportive housing setting, and how you monitor the delivery of those services.
They are if somebody is in permanent supported housing, first of all, one of the things around permanent supported housing is that we want to engage people in mental health and substance use treatment. However, there is consumer choice. So I just want to put that out there. But when somebody is in supported housing and they are connected to a core service agency, the core service agency is responsible for doing that assessment, developing a treatment plan with the individual and his or her family members, if appropriate, and then conducting and providing services on an ongoing basis. The goal is to begin to help the individual not manage their mental illness, if they have a mental illness or their substance use disorder, and be able to function effectively within the community and move to independence. So that's the process that's currently in place.
And then what's your process to monitor the performance of your service providers and success rates and such? What do you do?
We actually have published beginning in FY '22 a provider performance report that really looks at a variety of factors related to quality of care, timeliness of service, access, and so forth. And it's done by provider and by system. And so what we do is we look at those data and use those data to determine if any interventions are needed with a particular provider. And we will be doing that moving forward. As well as putting in place specific HEDIS measures and other quality of care measures that we will be tracking over time. The other thing that I'm very interested in reinstating is the community services review that we used to do some years ago, which is a case-based process for us doing like a 360 evaluation of a provider, looking at the person themselves and what they think, how they think about it, looking at others who are interacting with the core service agency, looking at internal staff within the core service agency, as well as our staff, our administrative staff. And so that's another tool in the toolbox.
And when are you thinking that
We
you'd
are in the
like to do
planning
that?
process now and looking at, what the feasibility is of moving back to a community service review process. But in the meantime, we have other quality measures that we're putting in place.
And when you talked with others about vacancies and you talked about the challenges in the hiring of psychologists and social workers and nurses, and your service providers face the same kind of challenges. How do you track the ratio, or what do the ratios look like of caseworker, social worker to clients? What's an acceptable ratio and what's not an acceptable?
We actually, through our certification process, have very specific requirements in terms of staffing. And upon review, we certainly look at that to determine whether or not someone will be recertified. Our providers are also required to have national certification, and we use those as measures to determine whether or not there's the right staffing, the right services being provided.
And you're comfortable that staffing levels today are where they need to be?
I think that there are certainly challenges in terms of staffing levels. When there is, they do have to inform us of that if they are not meeting the requirements, and they have to do a improvement plan.
And last topic for now, you do the CRT process, right? The community response teams, is that under you?
Mm-hmm.
And what is the response times? I mean, we hear in the number of police calls for mental health issues is sky high in some parts of Ward 3. And I'm wondering what's the wait time for a response from the community, from your community response team?
I'm glad you asked that question. Getting around the district, and we don't have, those red sirens that allow us to move through traffic quickly, certainly is an issue. And what we find is sometimes it may take an hour for the community response team to get to a site. However, we are looking at how to address that problem by co-locating staff out in the community, particularly within the bids.
In
We
the
have
bids.
the business, and actually, we have developed an agreement with Georgetown. And the downtown bid is very interested, so that we can put people actually in those locations so they can get there more quickly. And we are looking at what other business improvement areas and other businesses that are located in the community where we can use as launch pads to decrease the.
I'm out of time. We don't have any bids in the key areas that I'm
sorry?
thinking about. We don't have any bids in the key areas that I'm thinking about,
Businesses.
but UDC, I'll just put on the table. Thank you very
Yeah,
much.
thank you.
Thank you, Councilmember Freeman. Dr. Bazran, I want to pick up where both Councilmember Freeman and Councilmember Parker were asking. Councilmember Parker asked a question about the Access Helpline team. You said it's fully staffed. In fact, I think he was actually asking about 988. Are you suggesting that 988 and Access Helpline are the same team?
We do have specialized 988 staff, and there are vacancies within 988. There are 7 vacancies there, if I recall. Right? Right.
Hold on. I want to, Ash, if someone could fix the clock, I want to make sure that
I'm sorry.
we're fixing the timer, just to make
okay.
sure that I got too many council members here not to be equitable on my time. So I just want to make sure that we're good. Yeah. It's okay. In the interim, I'm just going to set a timer here, so we can keep going. So I'll keep myself honest. Okay, so I'm sorry. So you said there are 7 vacancies in
In
988.
the 988 line, Access Helpline, those staff are fully staffed.
Okay, how many people should be on 988, or how many FTEs are budgeted for 988?
Well, we 7 additional ones are budgeted for 988.
So a total of 14 for 988.
Yeah.
Okay. I was interested in the conversation that came up during the public witness piece where we're talking about diverting of calls. And I know that you all had this pilot that came out with much fanfare in terms of OUC. Would you call it a success?
Pardon me?
Would you call the pilot a success?
I would say it's a work in progress.
Okay. All right.
What I would
That's
say.
fair. So according to the data that you all sent, in terms of the number of calls from 911 that are diverted to DBH, you had in FY23, 28, and then FY24, 12.
Mhm.
I went to the OUC hearing prior to this, and their data looks a little bit different. But one of the things that came out of that conversation that I'm hoping you can help me unpack is that when OUC has a call that they are diverting, they are not calling the crisis response team. They are diverting or transferring the call to your Access Helpline.
Mhm.
Is that how this was supposed to work?
Yes.
Okay, so if you have somebody who is having a crisis, why are we transferring it to Access Helpline as opposed to 988 who could have an immediate response and talk to
Okay.
someone?
When 988 Access Helpline, I just want to be clear, when they can send those calls directly into the Access Helpline, into that 988, which is the crisis line.
Right, but that's why I
988,
asked you if
yeah.
they're 2 separate teams.
Yeah, they're 2 separate teams, but they're located in the same place, the same location.
Right, but where the call goes is important.
Mhm.
And let me tell you
Is it
why.
that-
I asked the director,
Yeah, that's what I thought.
okay, I asked the director of the Office of Unified Communication how transfer calls are going.
Mhm.
She said for December, they attempted to transfer 36 calls to the Access Helpline. 7 were picked up.
Mhm.
and one of their call takers had to wait 14 minutes for a response.
Mhm.
So if the whole point of the pilot is to divert calls, but Access Helpline isn't picking up the phone, how is this a success? Or
Well, I think that there are a number of issues that I have actually discussed with the director of OUC. We have found that there have been a number of factors related to the call answering time frame. A part of it has to do with just some equipment things in terms of making the transfers easier.
36 calls and 7
That's
picked
right.
up?
And
We're gonna blame the equipment director?
and the identification of which calls should be transferred. And that has to do with staff saying, we should be transferring X number of calls according to this protocol. There've been a lot of staff turnover. And so probably it should be even greater than the number that you had. It should be greater than that number. And that's something that the director and I are planning to work on so that we can improve performance. We both agree that this is not the performance that we'd like to see.
Okay, what is the average time that it takes for someone to pick up on Access Helpline?
2 to 3 rings.
Okay,
Mhm.
I had my staff do a secret shopper
Mhm.
because we had been hearing so many issues about Access Helpline.
Mhm.
That was not our experience across the board
Mhm.
on different days and at different times of the day. And so, beyond that, you mentioned to one of the colleagues that Access Helpline is supposed to now be helping someone sort of navigate through the process. Every time my staff called, they were asked where they lived. Then they were given 3 facilities that were in the area. They were not told whether or not they were accepting new patients. They were not told whether there was a specialty piece.
Mhm.
And so if this is supposed to be the helpline, how are you helping if you're not, if I still have to do all of the work? Which is what we had heard from a lot of providers around, even the hospitals have to call Access Helpline, and then you give them a list of places that they still have to have a nurse take time to call all of these places themselves.
Mhm.
But every time we talk about Access Helpline, you're telling me nothing has changed.
Mhm.
But everybody is saying it is not the same of what it was before.
Mhm. Well, as I said, I will, thank you for giving me that information and we will address it. That's all.
How will we address it? When will we address it?
But soon, immediately, we will immediately address it by taking a look at the processes that are currently in place and what's going wrong. And then checking through Secret Shopper to see whether or not there's improvement.
How many staff are on Access Helpline?
There are 28, right? Yeah, 28.
And there are no vacancies.
No.
Okay. So it's not a staffing issue.
Mm-mm.
What's the training like for someone on Access Helpline before they go live?
The training is, first of all, they get training on the use of the equipment, the protocols for identifying and addressing individuals that are in crisis, protocols and training on how to address some of the issues like mental health first aid kinds of issues that happen. And we also, by the way, have licensed clinicians on every shift in addition to the mental health folks that answer the phone.
Okay. So I asked OUC for their transfer report because I want to understand over the last 12 months how many times they attempted to transfer a call to you all and then it wasn't picked up. December was a snapshot. There could have been a variety of different reasons as to why that took place.
Mhm.
But if the goal is to not have MPD have to respond to non-violent mental health calls, they can't do that if the other side of the system is not even picking up the phone to respond. Because I think for some people, they thought OUC was transferring to CRT. And they're saying that's not what we do. We call Access Helpline and Access Helpline can dispatch or not. But I don't feel comfortable telling people to call one of these other places where if they're not going to get immediate response. And I think that's where some of the hesitation is coming in terms of diversion. If somebody is calling for an emergency, but it takes the CRT an hour to get there, that is why MPD is now still always the first line of defense
Mhm,
and not someone who is more well-suited or trained in de-escalation techniques.
mhm.
Is that what you hope to get to?
Absolutely.
Okay.
And absolutely.
I want to make sure we're on the same goal here, because if you guys don't want to do it, that's fine. Let's
No.
say that, but
No, and absolutely, and that's why we're looking at how to co-locate people differently so that we can reduce that response time so that they can get there quicker.
okay. Have you all thought about, for the CRT, co-locating them in a FIMS location?
You know,
FIMS, a firehouse.
no, we hadn't thought about that.
Okay.
Mhm.
I would, the bid offices are
Mhm.
business offices. They're there 9 to 5:30, and I know Councilman,
Mhm.
you know, so if CRT is running 24 hours, you gotta look for a place that's also open
They are.
24 hours, and,
Mhm.
and that might be an excellent, spot for that. Speaking of the CRT team, how is staffing there? I know we had some retention challenges.
Yes, we do have some staffing challenges in terms of CRT. We have 19 vacant positions right now. All of these positions are advertised, and we do expect to get a cert fairly shortly.
Right. Is it salary? Is it hours?
I think it's a combination of things. I think it's hours of work. You know, some people don't want to work, you know, shift work. I think it's also, it's hard work, very complicated work.
Okay, I'm over my time. Councilmember Nadeau.
Thank you, Madam Chair. Director, since we're talking about the CRT, I also want to talk about CHAMPS operating hours, because when CHAMPS was reduced, the CRT stepped in to cover the off hours.
Mhm.
And of course, adult care and care for children is different. I know you've said there's been no impact on care, but some of the witnesses on Monday raised concerns about the increase in hospitalizations for children, which is exactly what CHAMPS was developed to prevent. Is DBH concerned by this increase, and have you examined it?
Mhm. Megan, do you want to respond?
Sure. I think in our testimony, I think you can see the response that in 2024, 76 individuals that were served by CHAMPS were hospitalized. And then I think it was 48 during the CRT hours. So of course, we're always concerned about when youth or anyone is hospitalized. I think that we are, constantly trying to figure out, we want to provide the best services and obviously divert if and when possible. I think if you look at, on a different question, if you look at the number of inpatient youth, the numbers are about the same. So over from 23 to 24. So again, we aren't seeing a huge increase in number of youth who are being hospitalized per se. But again, we hear your concern in specifics in regards to the calls to CHAMPS and CRT.
Thank you.
And then the other thing too to note is that we do recognize the differences. You know, I come out of the child world, as you know. And so we are doing some specialized and some intensive training on the CRT team members so that they do have the skills to address the needs of children and their families, because kids, exist within their family structure appropriately. And so that is also happening.
Thank you very much. I was also concerned to hear about the involvement of non-behavioral health professionals, particularly MPD, in these situations. Can you explain the rationale for involvement of MPD and FEMS in behavioral health crises with children?
Go ahead.
MPD, I think sometimes when there needs to be transportation, so it's transportation, they're not assessing or doing the clinical aspect of it.
Why do we need MPD to transport sick kids?
Again, I don't know the specifics of these cases, but CHAMPS that is not part of they come and assess
Yeah.
and determine the clinical need and if they need to be hospitalized.
So we don't have like a medical partner that could transport them rather than police.
That's historically the way it's been done.
And do you feel like that's a good history?
And I think a part of it has to do with the safety factor. If safety is an issue, that's the instance in which, MPD is involved.
Okay, maybe if you want to do a deeper dive on the testimony from Monday, we could circle back on that.
Yeah.
Because if it's happening when there isn't an immediate safety concern, I wonder if we could brainstorm other
Mhm.
medical transport so that we're not scaring kids while they're having a crisis.
Mhm.
Okay, very good. That is all I have for today, Madam Chair. And thank you, Director and team.
Thank
Appreciate
you.
you.
Thank you, Councilmember Nadeau. Councilmember Felder.
Thank you. Thank you, Madam Chairperson. First question, how much of our opioid crisis response, such as Narcan distribution, treatment beds, and outreach programs depends on federal dollars, if any?
I can tell you that a lot of it is funded through our SOAR grant, which is $25 million. We also have funds through our opioid abatement fund, which is around close to $19 million over time. But then in addition to that, we also have services for substance use disorders that are a part of the billable Medicaid framework, and also services that are provided by us through our local budget allocation.
A follow-up question, what impact would funding cuts have on harm reduction strategies, medication assistant treatment programs, and crisis response teams?
It'll have a significant impact.
Are there any specific substance use prevention programs for youth that could be affected by budget reductions?
Actually, one of the things that we're doing in terms of prevention is we have put prevention curricula in all of our school-based behavioral health programs. Those funds come out of our local budget, and so they would not go away.
It's funny because my next question was going to be how would potential cuts
Yeah.
impact school-based mental health programs? What is the department doing to ensure that recreational marijuana education and substance use prevention programs continue despite possible budget constraints?
Okay, we actually do address that, and I'm going to turn it over to Dr. Sullivan because that falls within her area.
Thank you.
So just piggybacking on what Dr. Bazran said, all of our clinicians have been trained and have access for curriculum like Too Good for Drugs that can be implemented in the schools. And so thankfully those are locally funded. So it would be not impacted by federal dollars. Some of our other work too is also done at the prevention centers. We have 4 prevention centers across the city. And so in addition to implementing curriculum, some of our prevention staff as well as the partners work specifically with schools. And so things like classroom presentations to parents, things like that as well. So
Are there any alternative funding streams being explored to protect youth-focused behavioral health initiatives?
That's one of the reasons, quite frankly, why we have worked so closely with Medicaid to see how many services and supports we can make billable through the Centers for Medicaid and Medicare Services. And that's really added a lot of resources to our system. However, in terms of the other dollars that we have, we use our local dollar allocation. But on the federal side, we have both our block grant, our SOAR grant, and then we have some specialty grants that we've been able to acquire competitively that also support it. So we do have a large federal portfolio.
How does the department currently contract with community-based mental health and substance use providers, and what percentage of services are delivered through contracted organizations?
We have our system, the behavioral health system, in terms of the service delivery model is really supported by our provider network. And so we have 80 or so providers that provide both substance use, mental health, and co-occurring services. They are all certified by the department and provide those services. It includes evidence-based practices that we have, as well as the full range of services that are Medicaid eligible.
Have there been any delays in payments to contractors providing behavioral health services? If so, what is the cause of these delays and how is the department addressing them?
We've had delays in two areas. First, I'll talk about claiming, which is the MHRS and other Medicaid eligible programs. We also pay for non-Medicaid eligible, meaning that they're a resident of the district. They meet the federal poverty level threshold, but they are not US citizens. So they do not qualify for Medicaid payments, and we pay with local dollars. One of the things we're working with healthcare financing is to transfer that payment so that there's one payer. But the difficulty we run into before we do that is we have to close out fiscal years, and the DIFS system that we use to process payments does not allow us to run out an average timely filing period. It's 90 days.
Copy. I appreciate that. And I don't want to abruptly
Mhm.
interrupt you. I have about 5 more questions.
Councilmember Parker, he didn't answer your question, though.
Oh, I was trying to say if you could be a little bit more.
No, I'll give you more time because I'm interested in this, but he hasn't gotten to the answer to answer you.
So
Right.
on the
Thank you,
local,
Madam President.
Yeah.
the claiming side, you get delays there because we're trying to put traditionally the square peg in the round hole, and the systems don't support us running out where we have to accrue funds and close out a fiscal year when somebody still has the ability to write clinical notes and update files. So that's something that we've always struggled with. Again, payments slow on the grant side has to do with what we spoke about earlier. Again, we're reviewing, and to be honest, I think on the grant side, the most difficult piece is budget development and approval of invoices, because they too are submitted to a DIF system. You don't submit it and somehow miraculously they get paid. They have to comport with everything that lines up with a budget before they can be paid, before you can submit them for payment. So, I mean, there's been delays on that side as well.
So, Mr. Neff, are you suggesting that this is a CFO issue?
No, I'm saying on the grant side, it's the invoices prepared do not comport with a budget that needs to line up to allow for payment by payment categories.
Okay, we'll come back to it.
Okay.
Go ahead, Count. I stopped your time, so you're good. Go ahead,
I
Ashley.
appreciate that. Speaking about, just a follow-up on possible budget or funding reductions. If the federal funding is reduced, how will the department ensure that providers, particularly smaller community-based organizations, continue to receive timely payments?
I think that's a great question, and I don't know that I have a ready answer for it. We have been, I can tell you, I have personally been in constant communication with representatives of SAMHSA, the Substance Abuse and Mental Health Services Administration, to identify what the potential impacts might be. We have, our budget is our budget is our budget. And so we would have to look at, do we need to redistribute funds? What do we need? Do we need to decrease services? What needs to happen as a result of that?
How does the department ensure accountability and performance from contractors providing mental health and substance use treatment?
I think that was something that I was talking about earlier in terms of the fact that we do have, we certify our providers. They do have to meet certain standards, and we do follow up in terms of reviewing their performance.
Are there any specific workforce development initiatives in place to increase the number of culturally competent mental health and substance use providers in Ward 7?
Well, I can tell you that we do have health equity is one of our issues, and we want to make sure that we have people who look like the population of focus who are providing those services. That's something that's very important to us. And so as we review proposals and so forth, we do look at that as a factor.
Thank you, Director, and members of your leadership team. Madam Chairperson, I'll yield the remainder of my time to you.
Okay, thank you. Councilmember Freeman.
Caught me off guard. There was going to be others coming. On the CRT, I perked up.
What?
On the CRT, I perked up when you said 17 vacancies. Out of how many positions is that?
Pardon me?
17 vacancies in the CRT. Out of how many positions is that?
We have 64 positions.
So a quarter.
Mhm.
And I get it that the competition out there for talent is pretty fierce. And actually, as I listen to the testimony, and I think 60% of the schools are covered, you need people there. The CRT, you need people there.
Mhm.
When you look at it, how many mental health professionals do you feel like you're short today that we would need to find those people in order to fully implement the program that you want to see implemented?
Well, I think that some of the things that we're doing to address the workforce shortage are things like, for example, having relationships with universities. So that we really look at the pipeline and how we can really get people through the pipeline and into our service delivery system. And so we have developed relationships with 9 different universities that have, schools of social work and so forth. And we also are offering internships within our agency so that we can kind of grow people along, because that's one of the things we may have to do. The other thing is at St. Elizabeth's Hospital, we have a very highly regarded and intensive training program for psychologists, psychiatrists, and other professionals. And that's another place where we have been able to get folks, not at the level we need. We can't get, another 40% of the LICSWs, but it is where we're trying to go.
No, I hear you on all the things that you're trying to
Yeah.
do. I'm just trying to, I guess I have a sense that this is a 5-alarm fire that, it's hundreds. If it's 60% of the schools and the different categories, we're not talking dozens, we're talking hundreds of
Right.
mental health professionals who are needed.
And also we're looking at other strategies for how we might be able to get those services to young people, particularly those in the school. We talked about the 60% issue, but also we recognize that we are a part of a behavioral health team that's in the schools. There are other professionals that are in the school that are licensed, that are hired by the school. So what we want to do is look at the landscape. Who's really there? What are we doing? How can we better utilize the services that are there? And then use the other resources to put providers where nobody exists. That's one thing. And then the second thing is, how do we begin to use things like telehealth to provide services, which is another modality to address the need.
I hear you on all of that. So I'm going to pivot a little because I sense in the community I represent, there is a feeling that folks need more than they're getting. And
Need more, I'm sorry.
need more support than they're getting.
Uh-huh.
And it is a tricky thing because there are a lot of agencies that are involved in the setting of, say, using permanent supportive housing as an example. It's not just you, it's, and so it's tricky. The system is critically important. It has to work, but there are times when it doesn't, when you have situations, and you and I have talked about some of them. I think could even be that
In my house, yeah.
in your, and in that setting, there happens to be somebody present who can provide very rich services, but not everywhere. How often are there emergency transfers? What do you think of invoking emergency transfers where there's a tenant who is creating a serious issue in one place, and just to break it up and move them to a different place? Is that a tool that you ever are recommending using in a setting, or how do you deal with a situation where you know that there's somebody under your umbrella who's creating a real issue in a place?
And when you say emergency transfers, you mean somebody who's in housing who is having difficulty and moving them out of their house someplace else
To a different housing.
to a different house? No, we haven't, I have no experience doing that.
And what is it, when you hear about situations in your own building where, and I haven't heard anything from anybody there for quite a while.
No, we're good. I'm there. They know I'm there. So,
So, but there are other places, and when you hear about other places where there are issues like that that become acute or perceived as acute, what do you do? What
Yeah.
role do you play?
I'm going to have Dr. Muniz talk about a new grant effort that we are implementing to address individuals in scattered site housing.
Thank you, Dr. Bazran. But before I do that, I think we need to differentiate the types of housing out there. There are lots of different types of housing. For example, DBH has our own supported housing at various levels based on need, behavioral health and medical needs for people that either have severe, significant medical issues or functional impairments or mental health challenges. So those are housing vouchers or site-based vouchers that we manage, and we can help and facilitate people to move from one to the other based on their needs as their needs change. But we're often called in the situation that you're talking about, where, you know, we as DBH are asked to come and assess, support, refer, manage a crisis, behavioral health crisis, where it's a DHS housing situation or government's not at all involved. So in those situations, which is usually the more common instance, we'll go, you know, CRT is often the first call if it's a severe, significant crisis situations. But even when it's not, or if the person's well known to us, we have other staff through our integrated care division that will go out and try to establish a relationship with that person, assess. These are clinicians and peers who will try to assess their needs, try to develop a relationship and figure out what their needs, try to de-escalate what's going on that we can sort of manage and de-escalate. But oftentimes it's somebody with severe mental illness or drug and alcohol problems who is rejecting treatment and support. And in those instances, our options are very limited. And we certainly can't force them out of their house or move them to a different place. They have choice, you know? So those are the tough ones where, although we have this program, as Dr. Bazran said, where of folks dedicated to go to non-DBH sponsored managed houses to provide support, assessment, and treatment, it's a problem out there. Difficult to manage.
You can say that again, that it's a tough one, which goes to why I was asking about the assessment going in, because you can have somebody who ends up in a setting that wasn't the appropriate setting, and then you're stuck. In terms of the housing that you all do, I noted in the oversight answers that on supportive rehabilitative residents, you know, you've been up as high as 195, and now you're down to 166. I mean, maybe that's not such a big, maybe that's 13 vacancies in that context. But then and then also in supportive residents, I guess it's why is it that the capacity numbers in these spaces have gone down between 24 and 25?
Sure.
Go ahead. I mean, because of.
These are, again, we contract with operators who run these homes to provide support and services to individuals that we've deemed in conjunction with the provider as needing special supports and services to maintain community tenure, to live in the community. These are private homes. They're owned by private people. They're not owned by DBH. So these operators sometimes choose to do something else. They choose to close these homes. We've had a couple of instances where operators have died. We've had instances in the past where the operator has not met our certification requirements to ensure people are getting safe, appropriate care. So there are lots of reasons, but we'd love to maintain a steady state, and we encourage and support providers however we can to, if they're having issues, to maintain those levels of housing which are desperately needed in the community. But we don't drive that process. It's tough.
All right, well, I've run out of time, but need has not gone down.
And
Right.
I might say that right now, we know that these houses have closed. The 4 SRs, the 1 SRR have closed, voluntarily closed. And we have currently at 23 applications pending that we're reviewing for new providers so that we can get those numbers back up.
My time is up. Thank you
Okay,
very much.
I mean, I just wanted to make sure you knew that we weren't.
Thank you, Councilmember Freeman. We've been joined by the Ward 4 Councilmember Janice Lewis-George.
Hi, it's good to see you all. Thank you so much, Director and counterparts who are here. A few questions. I want to start first with drug-free zones. We passed legislation in the council last year through our Secure DC, calling for drug-free zones. I wanted to know, what presence does DBH have in drug-free zones established by the Metropolitan Police Department?
We actually have outreach workers in all of the drug-free zones. They
Okay.
are there on a daily basis. And they they also not just sit in the office. Oh, I'm sorry. I'm thinking about a different process. I'm thinking about the actual hubs. In drug-free zones, we actually will work in tandem if there's a need.
Okay.
Mhm.
So you're not, when MPD is establishing these drug-free zones, you come as requested or as needed?
Mhm,
Or
that's
are you
correct.
automatically do you automatically go to the rounds of those drug-free zones?
No, we actually participate and come as requested and
Okay.
needed. And we have a presence there in those areas. And our job is to do outreach to make sure if people need and want services, we
Uh-huh.
can help link them to those services and so forth. And we are alerted when a drug-free zone is going to be established.
Okay. And so you all, because we get emails too of sort of drug-free zones. I think most of us
Mhm,
get automatic emails. I imagine that that's what you all get.
Yeah, we do. Mhm.
And then do you then make a determination as an agency that you're going to go out, you're going to go to those zones, or do you wait for MPD to say, join us?
No, we just automatically go and
Okay.
provide that support.
And then what services are provided on site?
We, first of all, in a lot of instances, the outreach workers are familiar with the people in the area.
Okay.
And so we engage them. We also have naloxone, if people need that. We make sure that they have, a fentanyl test strips if they need that. And we, talk to them about whether or not, they, would like to get into care. We don't get involved in the police activity at all.
Got it.
Our job is really to work with people who may need services and
Got
supports.
it. And then our referrals, sort of, what services are referrals provided for?
That it can be provided for residential care.
Okay.
It can be provided for MAT care. It depends on what the individual is willing to accept.
Got it. And would you happen to have a sense of sort of how many consumers DBH have connected with through the drug-free zones and sort of what percentage of referrals have been fulfilled?
No, I don't have that information here, but we can probably get that for you.
Okay. I just say, as we continue to do the drug-free zones part, my ask is that the agency continue to be involved with the Metropolitan Police Department. And if you could sort of let us know how many consumers DBH is connecting with through those drug-free zones, just to see that
Okay,
those connections are happening and
okay.
we're able to do that work there. I want to move the crisis response teams. And if it's been asked and answered, just please let me know, Chairman or Director. You all set a KPI for achieving an average time from 911 call to CRT arrival on the scene for priority 1 calls at 30 minutes. It looks like you wrote that the 30-minute response time wasn't a helpful indicator. So I'm just curious of sort of why was it chosen for the KPI?
I think that that certainly was the response time that was chosen based upon information that we gathered.
Mhm.
Remember, as we were setting up the CRT, looking, across the nation in terms of what that might be, we are finding that our response time is way longer than that.
Got it.
And so that's something that we need to address because it takes us too long to get there. And that was one of the reasons why I was saying earlier, we are trying to work with the bids and with other trusted places to launch our teams from those sites. Because it's hard to get across the district, as you know, it's a very busy place.
Got it. And I agree, and by chance, sort of, what were the actual minimum, maximum, or average response times for priority 1 calls? Like what are we looking at?
I mean, I think the longest, could be an hour,
Okay,
and depending upon where we are, we could get there sooner, within minutes. So
okay.
it just depends.
What would you say the average is?
I think the average is about 40 minutes, about 30 to 40 minutes. Yeah.
Okay, got it. And then it looks like 29% of the CRT deployments requested MPD assistance. What are the types of deployments for which MPD assistance was requested?
But it's instances in which there's danger involved. There's a safety issue
Okay,
for the person and certainly for the team.
okay.
Mhm.
Can you give me an example what that would look like?
Somebody has a knife, somebody has a
Gotcha.
gun.
Okay.
And also MPD helps to transport. They will transport people
Okay,
if they're FD12 and they
If
need
they're
to go to the
FD12.
hospital. Mhm.
okay. And so I get transportation,
And danger, safety.
and danger safety,
Mhm.
okay, and ensuring that person. Do you know sort of how many consumers were arrested after calling CRT and sort of what percentage of the deployments for which MPD was requested resulted sort of in the arrest of an adult consumer?
No, I don't know. We can get that for you, but I
Okay.
don't know. off the top
And I'm
of
also curious sort of what, for children and youth, what that number is too, sort of like
my head.
how many consumers were arrested after calling CRT?
How many were arrested? I don't think any children were arrested after a call to a CRT.
That's great.
No, 0.
0, great.
Yeah. And I
Um,
don't think any of the individuals who were transported, but I'll find out on the adult side.
Perfect. Thank you. Your pre-hearing responses states that in all cases that the CRT engaged individuals and address their needs. In all cases, the CRT engaged the individuals and addressed their needs. I was wondering, how do you all define what counts as sort of an address need?
As
As an addressed need.
For example, if somebody is experiencing a mental health crisis, can we get them to a steady state and de-escalate the situation?
Got
If
it.
someone is out of control, can we de-escalate them and get them to a steady state or not? If not, can we then, if they meet the FD12 criteria, can we get them to the hospital?
Gotcha. Okay. Um, so it's in defining that space. Do you all consider, so like, I know this isn't possible. Does that mean, I was wondering if it meant like every consumer who was unhoused, wanted housing, received it, which would be ideal for all of us.
That would be ideal, but
Not realistic. So I get it. Your definition of that is sort of stabilized, on-site, hospitalized, whatever that
Mhm.
degree is.
Correct.
That's a better
right, and then we
definition.
also try to connect people to services, to
Right.
our core service
Got it.
agencies if
Perfect.
needed. Mhm.
That's what I wanted. Okay. Does that mean sort of warm handoffs were conducted, sort of that connects consumers with behavioral health services, et cetera?
Exactly.
Exactly. Okay,
Mhm.
great. That's amazing. Do you all have a sense of sort of what percentage of CRT deployments resulted in adult consumers being voluntarily hospitalized?
No, I don't know how many. I know that in some instances, people have been voluntarily hospitalized. I don't have the data at my fingertips, but we can certainly get that.
And what, I guess, I'm just curious, is in the field, sort of what, as far as voluntary hospitalizations versus involuntarily hospitalized, sort of what you all, what is the average of, like, what are you seeing? Are more people voluntarily hospitalized or involuntarily hospitalized?
I'll get the data for you.
Yeah.
Mhm.
Okay, I only have 18 seconds left. Are any adult or child and youth consumers transported to any other facilities as a result of CRT deployments?
Are the children?
Are any adult or child and youth transported to any other facilities as a result of CRT deployments?
They might be, you mean in other than a hospital?
Right,
They
like
might
a
be.
shelter
They
or,
might be transported to a hospital,
Huh.
for example. If they need a crisis bed, they could be sent there.
yeah, okay. So you all do, you do have the ability to transport them to other places outside of just
Yes.
the hospitals. They can be transferred to emergency shelters if necessary, is what I mean.
Yeah, they could go to emergencies, yes.
Okay, that's a possibility. Okay, great. Thank you.
Thank you. Director, I want to go back to talking about staffing. I'm going to come back to grants, Mr. Neff, but I'm waiting for the AFO to come back in the room because I feel like we need to get some clarity on that, but we could talk a little bit about the staffing piece. In the pre-hearing responses, you all indicated that 97% of the DBH employees received performance evaluations in FY '24, which I think is a great number that, you hit the 97% number. What was curious to me, however, was that there were no performance improvement plans issued. Y'all have over 1,400 employees and no one got a performance improvement plan. So how does the agency address situations where employee performance does not meet expectations?
In instances in which actually our supervisors are responsible for making those judgments. And in instances, if something comes up later, then there is a process for people needing to do a corrective action plan to address their issues through our HR process.
Okay. But that doesn't seem curious to you? No one's on a PIP? Everybody's flying high at DBH?
I think we have really good staff.
I'm sure you do. And
really good
this is not a knock on anyone's personality or things like that.
Yeah.
But on the other side of things where
Well-
I've got providers who aren't getting paid, I have folks who are calling and saying they're not getting an answer. So I've got to understand, like,
Hey, that was tongue in cheek,
Okay.
quite frankly. And because I do think that we do need to actually provide some additional training to all of our staff in terms of, the whole progressive discipline process and how it can best be utilized and how that then feeds into the annual assessment process.
Okay, so let's talk a little bit about the staffing issues with St. Elizabeth's. I don't know if y'all want to make a seat change there.
It's right there.
So there are currently a significant number of vacancies in terms of psychologists at St. Elizabeth's Hospital. 6 out of 19 positions are currently unfilled. And we heard from a representative of the union, and they expressed that one of the issues that they feel like is a challenge here is with regard to, we are not competitive against Maryland, Virginia, and the feds. Not a lot of jurisdictions have to compete with all three, but and also private sector, and we are having to do that. They noted that the starting salary for psychologists is 105, whereas in federal agencies it's 150. What are we? I understand that the CBA is coming open this year. Yes.
Yes,
Okay, so I'm hopeful that we can address this compensation issue.
yes.
Okay.
Negotiations underway as we speak.
Okay. Did you guys just start?
Mhm.
All right. Now, the residency program, obviously you guys get your training, which I think is a very unique thing about St. Elizabeth's, is that it is also a teaching hospital, right? Is that
Yes,
yeah, it is a teaching hospital. But my understanding is that none of your residents have stayed in the past 2 years after their residency has been completed, which it used to be a pipeline in terms of them taking permanent employment, or is that incorrect?
that's incorrect, yeah. So for psychiatrists, for example, about 60% of the practicing psychiatrists at DVH trained in our programs. We're hiring, for example, I think 2 or 3, hopefully 3 psychiatrists from our training programs this year,
Okay.
this coming year.
Mhm.
And so they will finish the program, their 4th year residency in July. And 3 of them have signed up to join us as an example of our training and retention.
Okay, but that's psychiatry.
Yes,
Okay.
our psychologists, we have some vacancies because our compensation has been so non-competitive.
Okay.
And so as we address that, and the mayor did address that for trainees in the past year.
Yes.
So now we're filling our slots, more trainees, more to recruit.
Okay. Is there anything beyond compensation that you all can do now?
Yes, well, we treat them well. We work, no, that's very important. Establish relationship.
Yep.
We select excellent students,
Mhm.
and then we work with them. And we relate to them in a way that we have a career path and plan for them
Okay.
if they want to choose us.
Are you at all concerned that, well, let me ask this differently. Have the vacancy challenges at St. Elizabeth's presented a challenge in you all meeting your legal obligations in terms of assessments and otherwise?
Yes, not as a single issue, but as part of our inability to recruit because the compensation has not been competitive, which is under negotiation as we speak.
Okay.
We hope to correct that. The psychologists are a critical part of our clinical team and our treatment program. And so they're essential to our success. Have been historically. We've hit a period of non-competitiveness, but that's being worked on.
Mhm.
And it's a top priority with our director.
But we have met our requirement for psychological evaluations for the courts.
Yes.
I'm sorry, say that again, Dr. Casper.
I said we have been able to, with the existing staff, meet our requirements for,
Okay. There was some concerns raised about lack of capacity for civil commitments as the number of forensic placements have increased.
oh, I'm sorry, I was just trying to finish my, so go ahead.
Oh, okay. I was moving on to another
Okay.
question. My staff and I, we came out to St. Elizabeth's and we talked a little bit about how does one find themselves at St. Elizabeth's, right? Which I think is perhaps not what the public might understand. And that right now, in some ways, you really can't get a permanent slot, well, not permanent, but you can't really get a slot at St. Elizabeth, but for the courts. Or going through the court process. Is that accurate?
No, there are two ways. You're
Okay,
transferred from Washington Hospital Center, PIW, or UMC after staying for a short period, 2 weeks. And then you are either transferred after that 2 week period, or you go on a wait list.
right,
As of today, this hearing, there are 0 patients on our civil wait list to be transferred, seeking to be transferred to St. Elizabeth for long-term treatment and care.
really?
Yes. It changes from day to day.
Yeah.
And it goes, this is an unusual situation that changes every 24 hours.
Mhm.
But we're very responsive to
Okay.
both the courts and to our partners in the community.
Okay, so there is a perception that St. Elizabeth does not have the capacity to accept civil commitments because there have been so many forensic placements.
Well, there are wait lists from time to time. It varies during the course of the year, the fiscal year. It goes up and down, but we're very responsive. We're very aware, and we make operational changes to meet the demand if the wait list increases.
Okay. While you're sitting at the table, I want to ask about capital projects, because my understanding is that much of the capital budget is with St. Elizabeth's for DBH. According to the pre-hearing responses in FY24, you all have budgeted 22 million for a variety of capital projects. I think you might have made some upgrades at the facility. Yet we're showing that you only spent about 6.6 million. So I'm assuming that there were some projects that were delayed.
Yeah, so the delays occurred during the COVID years. Contractors actually had refused to come on site for fear of contracting the disease.
Correct.
Now
I'm
that that
talking
has
about,
subsided,
I'm talking about now.
I'm sorry, yes.
Yeah.
I'm getting
Oh,
to this
okay.
moment, yes. So we have caught up, moving the projects forward. We have a number of projects like replacing our paging system, replacing our camera security system, et cetera. So those projects have been developed. They're with our procurement department, and they're moving them along in the process. That's millions of dollars of capital projects that are moving through the process for purchasing, identifying vendors in accordance with our rules as we
Okay.
speak. So
All right, we're gonna check in on this on budget. Can't just leave millions of capital dollars just laying around, because somebody might scoop that and take it for something else.
we're fully aware of it.
Okay, all right, I'm over my time. Councilmember Freeman?
Ma'am, may I add something?
Sure.
Okay, I just want to make sure that we all are clear that the Department of Behavioral Health does not negotiate the CBAs. We do not do that. The Mayor's Office of Labor Relations actually does that process, and we are a part of the overall contract for the District of Columbia.
No, I'm aware. of that.
Okay.
That is
Just
not you
wanted to make
guys.
sure.
Yeah, no.
no.
All right, Councilmember Freeman?
Thank you very much. Back on permanent supportive housing, SAMHSA has like an evaluation tool that for permanent supportive housing programs, and I wonder, do you use that? What do you do in terms of evaluating the success or failure of the permanent supportive housing programs that you are a part of?
Well, I know that we do work with DHS also around that, and the VD for that is probably one of the things that you're thinking about. We do use that as a part of our assessment tool for people getting in. The other thing we look at is retention in housing. If people are able to remain in their housing, or if there's motility and moving around, and we find that we are doing pretty well with that, over 90% stability in terms of the housing. And then we also will look at individuals who are having difficulty. And what kind of supports do we need to provide for individuals that are in our housing? Do we need to make sure that the core service agency is doing the services that they need to do in order to help people maintain community tenure? Community tenure is what we look at in terms of that.
Yeah, and I saw that and it, I mean, that is important, but the part of the idea behind Housing First, and you may come back to the table in a bit, but part of the idea of Housing First is you provide housing and then everything else improves. And so you do want to be tracking whether or not everything else is improving, mental health conditions, et
Jobs,
cetera.
yeah, all of that,
And
employment.
so, and then you get into a world where you want to see what kinds of services people may need, but you get into a world where you may have people reject services. And so that's the hard spot that we were talking about before. There are, I think the original permanent supportive housing first model made acceptance of services a requirement. We don't.
No, to my knowledge, I was trained in that model. Housing First was that people did have consumer choice in terms of whether or not they receive services or not. We have implemented a process for people to have to receive services, some of our.
So I'll have to go back to
Yeah.
core documents and come
Right.
back to you on that. And I'm not right in this moment arguing for that.
Right.
It's just that the
Yeah.
hard spot that we get in
Right.
is a hard spot, and I'm wondering, trying to figure out how to deal with that. And it may not be you, it may be DHS, which I now have oversight over, but this back and forth about how do we address that difficult issue, I think is important. I'm going to go to a different topic that we haven't talked about yet, and I don't know if Chairperson Henderson was intending, has a big section deep into the evening on this, but PIW. And PIW is in Ward 3. There was a hearing last year about PIW, about many things, but including PIW and some of the challenges that they have faced. And there's the disability rights report that is out there that, has to be a source of concern for you. You may have answers or to things that were raised there. One of the things that I asked about, if I'm remembering correctly, was something like, what's the ratio of staff to patients that's required? And the answer, if I'm remembering the hearing correctly, was there is no specified number, but then you dug a little deeper, there are guidelines or there's an industry standard, and we didn't really hear what the industry standard was. So there is some kind of a requirement. And I guess my question, fundamental question to you is, you have oversight over all of the folks who you have contracts with. What are you doing in terms of oversight over PIW to make sure that they are delivering in a way that everyone can be proud of?
I'm so glad you asked the question because we have certainly enhanced our oversight of PIW since over this past year. And so one of the things that we're doing is that we go on site twice a month to physically look at what's happening on the wards. And we go through a whole checklist in terms of things like, what is the staffing there? What are the activities that are there? What does the physical environment look like, and so forth? And I have a licensed social worker as well as an advanced practice nurse that are a part of that team. And then at the end of that visit, they do a report out with PIW and say, these are the things that need to be addressed. It might be, you have people just in bed all day, as opposed to having activities and being able to move around. What we have found is that the increase in oversight, and that's just the on-site. In addition to that, on a weekly basis, we actually do a case review of the people that are in that unit. What we're finding is that we are seeing some change. You know, we are seeing things change.
So on those visits, are those scheduled visits or are those that you just turn up?
I'm sorry.
On those visits, those twice a month visits, are those scheduled visits or are those you just show
Some
up?
are scheduled and some are unscheduled. visits.
And different times of day?
Pardon me?
Different times of day?
I don't know the times of day, but I can find out. But I do know that we have those scheduled, those 2 visits. And I think that that's really making a difference from the reports that I see and have looked at in terms of the environment of care, what's happening, and the staffing.
And I spending a lot of time here today, but not technically on the committee, so it could be that it's a failure on my part, but are those reports already shared with the committee? The reports of your
I don't think
ineffectiveness?
so. No, No, these are reports that I know I get them and I review them. And because I also meet on a regular basis with the CEO of PIW to talk about any issues that need to be addressed. I personally do that.
Yeah. Okay, well, obviously, and the disability rights report was troubling. And so
Mhm,
we
sure, I
all
agree.
want to be sure that,
And I think as a result of that, a couple of things happened. Dr. Bennett, understanding that PIW is a hospital and DC Health is the agency that has the responsibility over them in terms of their licensure and so forth. And she and I went together to PIW to look at what was happening and how they were addressing the things in the disability rights program. And so my follow-up is what I've told you around the behavioral health piece.
all right, and I should add, and the disability rights report was one of the things that raised concerns, but it wasn't the only thing, and we heard from a
Right.
variety of people. I'm going to close out. Perhaps I should know, but what role do you play? Are your people serving folks in encampments? What's happening in that space, and what role do you play if there's an encampment clearing?
We work very closely with DHS around encampments and provide the support to the people who are there. And that includes outreach support. If people need to be connected to care, we do that. And that includes our outreach and engagement team, as well as our community response team.
All right, I'm going to leave a minute on the table, and thank you very much.
Thank you. Dr. Balzeron, after Councilmember Lewis George finishes, we'll do a 5-minute break because we've been sitting for about 2 hours.
Okay.
And then
Thank you.
back. Councilmember Lewis George.
Thank you.
Thank you.
Congratulations to you all on the opening of the DC Stabilization Center. Was really excited about that, and really excited about the work you all are doing there. As you all, maybe 2 years ago, I was asking whether you all were going to consider doing sort of safe, making it a safe injection site, or what were you gonna, or what you have gathered about whether that would be something that we should be considering as a district. I was wondering if from the services you're providing at the Stabilization Center, has that come up as a consideration, or if so, what was the sort of outcome of that consideration?
Well, first of all, we have seen the Stabilization Center, we see it as a great success. I mean,
Yeah.
when you have over 7,600 people
That's right.
coming in and out, and if you have 22% of the individuals being connected to care, that's good news.
Absolutely.
And so we have found that really as an easy, low barrier pathway to care. We have not, in terms of a policy choice, really, we went out and visited the one stabilization center, safe injection site that's available in New York. And I
Right.
believe
Yeah. Yeah.
Councilmember Henderson and a lot of you also went. And we have also gathered some additional data. Right now, the deputy mayor's office is really taking the lead
Okay.
around that.
Right. Awesome. Well, I was excited. I agree that the Stabilization Center is a success and you should consider it as a success. And I'm really excited and thankful for the work you all are doing there. Visiting New York and that I always just remember being amazed at what I once thought was not a good answer. And I was convinced there that it would be a good added consideration. So I appreciate the work that's happening and any progress we make on that front. I wanted to ask about how many people are on the wait list for transfer from St. Elizabeth's from DOC. Are they all for competency evaluations or are there other reasons for transfers as well?
So today there's 6. I check it every day, so I know. So there's 6 today. And they can be either for competency evaluation or restoration or other treatment.
Okay.
Mhm.
What is restoration?
They were incompetent at a moment in
Long
time,
time.
and they need to be provided treatment to be competent, to become competent, to face their trial and charges.
Mhm.
And so that's the treatment they would receive to restore them to competency
Got it.
and prepare them to go to trial. So they understand fully what's occurring.
Got it. Understood. And then what are we doing for youth that may be deemed incompetent to stand trial? What does the process look like for youth?
So at St. Elizabeth Hospital, we only treat adults,
I
18
know,
and
that's
over.
right.
Right.
Oh, I know that. I'm asking, what are we
Dr.
doing as a city
Yeah,
as
and
it relates to youth?
Young people, and certainly Dr. Sullivan can chime in on this. DYRS is responsible for that service.
I will ask you, right? I was gonna say as a I would add a follow-up. I'll just ask you, right? I can follow up, but I won't do it there. Because I don't want to put you all in that position. Question about sort of, we had this issue where sort of, and I'm just curious to what it takes. We had this issue where we're calling out the crisis response team to a neighbor who was experiencing a mental health incident where he was literally blasting music in the neighborhood, running around the yard, threatening neighbors, throwing rocks at neighbors, houses and cars. It became a sort of daily occurrence in the neighborhood. And people were aware that it was likely mental health issues, but it became scary for neighbors, especially those with children, because he would be like literally walking into people's houses. I don't know why people have their doors open, but people do leave their doors open. And he would be walking in their houses, and it was scary. When they kept calling, and then it was back and forth with the crisis response team and MPD, and MPD was like, well, we asked the crisis response team to evaluate him, and they keep releasing him, or it was just a back and forth for weeks where this incident occurred. I guess I'm curious as to what goes into, I guess it's a medical basis for which the determination of whether an individual in those instances would be held or released.
Yes, the person has to be a danger to self and others. There's a very specific clinical criteria in terms of whether or not you can commit somebody to the hospital through an FD-12.
Okay. And so I guess we were going back and forth with, it was MPD, DVH, we were going back and forth because they kept saying, well, these are what he was getting were misdemeanor terroristic threats, those small things. And those cases are not going to be papered if by experience. I know they're not going to be papered, but in MPD's experience, they're not papered. And so everybody was like, well, why won't they commit him if this keeps being a recurring incident? We're literally calling every week because he's doing the same action. So I guess I was curious what that medical criteria is as far as harm to others versus harm to self.
My medical director is here, so I'll have him come up and address that. Here you go, Dr. Shepherd.
So good afternoon, everyone. Just in relation to this particular incident,
if the person was conducting that behavior, if MPD saw the behavior but the CRT team did not see it, then the CRT team could not write that FD-12. So we need to find out what, who actually saw the particular incident.
Right.
So what Dr. Bazran has described is the criteria, but it really relies on who saw the incident. Because if you take that to court, I'm gonna tell you right now, the court's gonna throw it out because it said it was hearsay. So you have to be able to prove when you write that FD-12,
Got
who
it.
saw the examples of what you're describing.
Okay, so that makes sense as what the holdup was, because I mean, neighbors are experiencing it, neighbors are seeing it, they're then calling MPD, MPD's responding, individuals going to evaluation. And from neighbors' perspective, MPD is saying nothing we can do, and DBH is saying nothing we can do. And we were in a sort of that spiral for
Yeah.
weeks
Now,
on
both,
end.
I was just say MPD can write FD-12. So sometimes there's some resistance in that, to be honest with you. But
Okay.
again, they can write FD-12s.
Oh,
So.
all right. So in general, because now that makes sense, because that back and forth was taking forever to figure out. And I hate when there's like they do it situation. I sort of figure out who needs to do what. What should neighbors do in this situation, sort of in general? Keep calling CRT daily, or what are the other alternatives? Because I don't want to be that we're frustrating your system. My hope is we don't frustrate your system but that's what was happening. I think neighbors were frustrating the system because they were going to you, calling you all daily and calling MPD daily.
Yeah, it is a frustrating system when you have someone who's in the neighborhood and you're trying to get them the help that they need. It is a
Yeah.
scary situation
Yeah.
as you're describing. So what I would say is you can call MPD if need be, if it's a safety issue. But I would say we also have people within DBH. We have our ombudsman's persons and people like that when there are complaints like that, they reach my office. And so once it reaches my office, we're able to make a determination to see if we can get someone out there to actually view
Observe.
and observe what's happening.
Okay.
Yes, ma'am.
And you all can't consider like video evidence or anything, or you nor MPD can consider like video evidence for an FD-12, or it's just not preferential.
Yeah, I'm not a lawyer on that, so.
Understood, I got you. Okay. So the best way would be to get DBH out there, to get MPD out there for one of them to see this happening in real time.
Absolutely.
Got you. Awesome. Thank you. Councilman Henderson covered my other questions. So that's all I have, and I yield the remainder of my time. Thank you.
Thank you, Councilman Lewis George. We'll take a 5-minute break to get up, stretch, go to the bathroom, and we'll be back. 5 minutes. Thank you.
Nice to meet you as well. Oh, thank you.
Yeah, absolutely. Yeah.
Um,
So if something like that happens.
yeah, okay. Yeah, it was crazy in the summer. It was like that every single day they were calling like,
Yeah.
he's in my neighbor's house in the yard and da, da, da. And I was like, oh my God.
Yeah, we've had those type of cases
It's
before.
getting frustrating. And it takes a long time to respond.
you're a member of my family. This is my maiden name.
What?
George is.
George is your maiden name? Oh my goodness.
So you're a member of my family somewhere. Oh,
Okay, we are back. We are alone, so let's see where we go, or if some of my colleagues join us a little bit later. All right, I do want to go back to grants because I mentioned that before. So we've heard some serious concerns from providers who testified on Monday, and even before then, about substantial delays regarding grant administration and payment process. And when they come to us, I'm like, well, I know DBH has the money. You've had the money. So it's not a question of can you pay? It's a question of what is the processes and why are payments so delayed, such that I've got organizations who are struggling to make payroll. I have organizations who are taking out personal loans, and none of that is necessary. And so I'm trying to understand what's happening here. Okay, so one of the questions I had was around, now you don't have a grants management system, so this makes it difficult, but like to the extent that you all are tracking delayed processing for payment, is there a way for you to look in your system and say, this is when we received an invoice and this is when it was paid?
There is a way for us to look into the financial system to see when a sub-grantee submitted an invoice, and then we can see when it was paid.
Okay, so what are we averaging right now?
I haven't looked at that report, but I can get that number back to you.
Okay.
And I just want to be clear on receiving an invoice. A lot of times the invoice cannot be submitted to accounts payable or approved for payment because the invoice does not have the proper documentation for things as simple as the correct PO number or as simple as the grant deliverable line. And for example, if we were issuing or the agency was issuing one grant to a grantee, one line would say for children from 0 to 3, and another line would say for children from 4 to 6. The vendor would bill us on the 0 to 3 line on the PO line that's for 4 to 6, ages 4 to 6. So the invoice would have to be sent back because we have to manage our deliverables accordingly.
Okay, so, but then whose responsibility is it to communicate with the grantee that they are submitting documentation incorrectly?
The program communicates with the grantee about that.
Okay, how often is it that you all are unable to pay due to a particular mistake like that? PO, you know, I'm not gonna, these are clerical mistakes. And I recognize that some of the organizations for which you might be granting with may not have the back office staff to handle these processes. But if you are seeing a mistake frequently, I would anticipate that the program staff would have a conversation and say, look, this is the proper way to document so that you can pay and so that you can also be paid on time. And we're seeing this frequent mistake. Is that happening?
The program staff does manage this process, and I'm removed from that part of the process.
Oh,
but
yes,
I
let me clarify. You never introduced yourself.
I'm sorry, I'm Adrian Reed, the Agency Fiscal Officer for DBH.
Okay, so then I guess my question for Director Bazran or for Mr. Neff is, what then is the steps that the program staff are doing? If the folks on the CFO side are saying, look, we are seeing wrong PO numbers, wrong this, wrong that, whose responsibility is it to go back to the grantees and say, you guys are not submitting your documentation properly?
It's both the responsibility when Adrian says program, he's referring to all of us. So it would be twofold. One is what internally we would call program, which is the like SOAR group that oversees SOAR grants, combined with a fiscal monitor, and they're in the fiscal services area. The reason we have them separated is we have to follow gap procedures and any type of granting, meaning that if you can approve a program, you have to be separated on the financial side.
No, I understand.
Okay.
Are there any types of grants that are delayed more than others? Like, who's the problem child? Children.
No. Yeah, well, yes, I suppose that's a better way to look at it. People who are new to submitting grants. I want to be clear that we have many providers that are very experienced in both submitting for federal grants and becoming subrecipients to DBH, and do a wonderful job of submitting because they submit their budget is clear. The gap part of it is the most difficult, are the direct and indirect costs aligned with the spending plan and the budget. That's the most difficult part that we have to reconcile. And I hate to say, sometimes it takes a couple of months before we can get a correct invoice that matches the grant, that we can have approved and say, yes, please submit it. And we
It could take a couple of months to receive the correct invoice from a provider.
It absolutely can.
Okay. And all the while, they can't actually do anything.
Well, they can.
I mean, they can, but it's,
Payment, correct.
they're not receiving any payment for it.
Right.
Um,
So we have a number of things, and that's why we're excited about an electronic grants management system. On the front end, you can have the template set up not to allow certain categories to go into a budget field. And so you can really structure as they're working what they need to do to complete a budget properly. And that's the other reason we want to do videos to show, here's the form, here's the categories that can go in it, et cetera. I think the more we can do on the front end, and then the quicker we can approve it, the better chance we have of making sure that the invoices mirror the categories within the budget of the grant.
Is there a limit on how far or how backdated an invoice can be submitted for? So for instance, let's say I completed the work in October, but I didn't manage to get you a corrected invoice until February.
No, there isn't. There just has to be clear communication between the vendor and the program. And most times there is clear communication, and we can set up the funding structure so that funding is available in anticipation of that late invoice.
Okay, so, where I am, my sort of tension on the federal grants piece, so I understand sort of the provider part of it. I also feel like, given everything that's going on, particularly on the federal context, like provider, like we cannot sit, because if you sit too long, that money might not be there by the time you get around to getting us your invoice. And so I want to understand what the communication plan is to ensure timely payment, right? I mean, we're seeing efforts to pull back monies that have already been awarded. And so how do we explain to our grantees, look, things have changed in the last it's only been 2 weeks, 2 weeks.
So I can say, as Dr. Bazwan stated earlier, that she got a team together. She recruited me to be a part of that team to look at the procedures of the grant making for the agency. And one of the things that the agency plans to do is to have more technical assistance. And that's what Michael was just speaking to as far as the video, so that things can be more accurate on the front end, and it can significantly reduce the amount of time between the back and forth that it takes for a proper invoice to be submitted.
Okay, how many people do you guys have on the grants management team?
Well, there are 7 on the fiscal services side, 4 on the grants management side, and depending on, again, the DBH program side, SOAR is probably our largest with, don't know, I'm going to 9 staff.
Okay,
So that would be for SOAR, smaller for opioid abatement.
Oh, yeah, you have 3 staff there.
okay. Because in other agencies, it's those types of individuals who are also providing technical assistance as well. And so that's why I'm a little confused when you say we'll provide technical assistance through this video, when you have staff who can have these conversations.
Yeah, we have, for the budgeting and invoicing, we have 7 positions, 2 of which are vacant, and 196 grants.
To 5 people doing 196 grants. Okay.
And one of the things we're looking at is how much of an additional resource is needed so that we can shorten this time frame.
Okay. I was pleased to see a reduction in the federal grant underspending for FY twenty-four. Again, I don't like to give them any money back, especially since we don't have representation in Congress. So I feel like it's our tax, you know? So I think we only, FY twenty-four, had a budget authority for 40.4 million. We had expenditures reach 39 million. So I think that's fairly good for us, but I would like to, of course, spend it all. For FY twenty-five, they approved budget authority and federal grants is 45.6 million. And we have 5.5 million expenditures to date. However, there seems to be some lagging in terms of our rate of spend on the federal side. Are we monitoring this to make sure we're not gonna give money back?
We are monitoring, and I just want to attest to it that the numbers are as of December 31st, 2024. So
Okay.
there have been some changes since then. I can't quantify the changes right now, but I can follow up with you and provide you with an updated report.
Okay, that's helpful to know. So in terms of, all right, hold on, I'm trying to think. All right, we have this grants management system in August. It goes live in August, or it will be fully procured by August?
No, it'll be live in August. We're at the very last piece, we have to do demos, complete an MOU with the cost for the copy over, and we should be ready to execute that.
Okay, and then training for staff?
Training for staff will probably be then July.
Okay, in terms of federal grants, and I think Councilmember Felder kind of alluded to this, right? We have a significant number of federal grants, particularly as it relates to our harm reduction strategies and efforts. SOAR probably being the biggest in terms of the block grant pieces there. Do we have any contingency plans? Or are we working on any contingency plans should any of these grants experience funding shortfalls or significant delays?
I can tell you as of last week, we were still trying to, well, as of a few days ago, we really didn't know what was happening. And I don't think there's any clarity at this point in terms of what's going to happen. And so one of the things that that I have personally been doing is remaining in contact with both NASDAQ as well as NASHBIT, the national organizations for behavioral health, to get some sense of what's happening on the ground, you know, in terms of the federal government. And we're keeping our eye on it. We have met with providers and alerted them of what's happening and encouraged people to draw down as much resource as they can. We have done that internally as a means of capturing as much of the funds as we can. And then we have to continue to have that conversation with our federal partners so that we can get more information.
Okay. The Office of the Inspector General released their follow-up evaluation last week on DBH's management of the state opioid response program, funds as well as resources. I was pleased to read that DBH has implemented all 10 of the recommendations that were outlined in that report. But it did include 3 opportunities to improve. The first was around uniform administrative requirements for training at regular intervals so that
That's right.
current and future
And we
staff
plan to do that.
know their grant-related responsibilities, et cetera. The second was updating the policy manual to ensure that the current it is aligns with the current guidance that is out there. And the third was to prioritize the development and implementation of an automated grant system. You know, this automated grant system. Everybody is telling that.
And we plan to do all 3 of those things, yes.
Okay, so in terms of updating the policy manual, what's happening there?
You've done that already. Grants managed. Policy.
We have updated many of the policies. We actually are working on one. We did it this morning on charitable contribution. So that is something we're in the process of reviewing to get ready to implement an EGMS.
Okay. All right. My colleagues covered a lot. So, let's talk about, inpatient, and, you know, obviously we had a hearing on this. So, I think some of these questions we're sort of well versed on, but I want to, touch in on a few things. So in the pre-hearing responses, you all talked about 2 social workers who process FD12s in the responses, and I thought that was a little strange that you only have 2 people who are doing that, and perhaps that could have been a typo in terms of how that was communicated, and so I wanted to ask some questions about that.
Okay.
Thanks,
Your
council
thing.
member. Those staff report up to me. It's 2 clinical staff that manage the clinical aspects of the people committed inpatient on an FD12. So it's not 2 people managing FD12s, but 2 people that are ensuring that those folks in-house are getting the proper care and facilitating discharge and connection on an outpatient basis.
Okay, so we have a high number of FD12s. I think approximately 2,700 annually, and you have only 2 clinical people. Is that enough?
Also, the ICC does it.
Well, I think she's talking about the
Mhm.
inpatient process. We have other staff that facilitate the support once the person's out of the hospital.
Right.
But that's the number of people we have managing to ensure that people are getting what they need and then facilitating the discharge and connection to care. We certainly can look at that. It's a
Okay.
challenge, but I think those folks are working very, very efficiently because they're not necessarily seeing everybody themselves and doing evaluations. They're getting records, they're connecting to the outpatient provider. So they're almost like an air traffic controller, rather than.
What an analogy to use now in terms of air traffic control and caseload.
Okay.
And I'm saying that because when we have these conversations about staffing and retention, I gotta look at, do we have 2 people doing the job of 6? And is somebody leaving because they're like, I'm doing the job of 6 people and nobody is coming to help me and support. And so as we think about some of these things, I think we need to
I hear you.
sort of look at the numbers
Yes.
there. Now, we had Dr. Bazarn, you were here for some of the public witness testimony. We had a witness who testified on Monday that I thought was a pretty harrowing experience involving involuntary commitment. She called the National Institutes for Mental Health. Yep.
I heard her.
And, described what I thought was a lot of failures on our part in terms of the system, right? Whether it be put in the 4-point restraints for over 2 hours, being shamed by the EMT staffer for needing to be at PIW, the lack of treatment she reported. What do we do in these situations to improve? Because I feel like now we have a situation where for her or anyone in her orbit, they're not going to call when they need help anymore.
Well, first of all, and I don't want to get into her specifics, but I think that also she was in need of support, just like she said. And one of the things that we're looking into is exactly what happened and doing a case analysis to see where things kind of did not go the way we think they should go in terms of that. That to me had never raised up into my level. And that was the first time I had heard of that.
Okay.
And I did go back and talk to our chief medical officer and said, look into this, let's find out what's going on so that we can see exactly what happened. But she really was struggling.
Yeah, I think also too, I mean, and I don't know, and this is maybe a something I'll talk to Chief Donnelly about, right? There are any number of reasons as to why someone could be at PIW and it's not criminal in nature. And so
Right, yeah.
to suggest that whatever you did to get here, you deserve, like, that's unacceptable on our part. And so I think that's a training piece with FEMS around, understanding that not everyone who is in an FD12 situation is because of some sort of criminal behavior. The pre-hearing responses mentioned a nurse care manager has been added to the team to follow up on post-discharge care. Do you feel like this has been an effective intervention in improving follow-up rates?
From PIW?
For discharge, post
From any
FD12.
hospitals.
Yeah.
This is a hospital.
This is
Yeah.
one staff dedicated to PIW. Again, it's adding additional support to ensure that we get the best outcomes possible.
Okay, so that person only does PIW cases?
For for involuntarily committed folks.
Okay, so what happens for all of our other hospitals who have FD12s? Do we do any post follow-up?
It's for all
It's
involuntary.
all involuntary.
Regardless of which
involuntaries.
hospital they go.
Okay.
That's what I meant.
Okay, yeah. So we said only PIW, I was like, wait, okay,
Yeah.
Starbucks. Okay, so, I mean, what type of data are we using to track effectiveness?
Ability to get an intake, to lag to first appointment, tenure in the community, ensuring that the person is not re-hospitalized, as often occurs very soon without that kind of support.
So how long has this position been in part of the team?
About a month.
About a month. Okay, so we're fresh. All right, so we'll check back in to kind of see, is this working? And is it, not? We had this, no, you were not at the hearing about Cedar Hill and UMC.
No, I wasn't at Cedar Hill, but I listened to all of our testimony.
No, but I was like, no, you weren't there.
No.
I'm curious as we talk about FD12s and sort of the transition of UMC closing and Cedar Hill coming online. As you know, Cedar Hill has less FD12 capacity than UMC.
That's right.
And so what are the conversations with the other hospitals around what might be a potential increase?
Well, first of all, what is and was a CON that was approved to add 22 beds to PIW. That was one of the things. There are a total
For adult?
for adults.
Okay.
Yes. Okay, the second thing is that the Hospital Association leadership and I, along with Dr. Bennett, are working with all of the CEOs of all of the hospitals within the community to develop a surge plan. The thing is that we feel and we know that we do not have enough beds to accommodate any future needs. And so we want to make sure we have a plan in place in terms of how we address that with the closure of UMC. So Jackie Bowen and I are working very closely to organize that and to get that plan in place.
Okay. How will we monitor volume? I guess, frankly,
How do
I'm
we
sure we'll hear
monitor?
from some of the hospitals should they feel like they are overburdened.
Well, actually, on the FD12 side, in terms of the hospitals that we have contracts with, Dr. Shepherd actually does collect data and monitor what's happening in terms of utilization.
Okay. One of the things in terms of the FD12 continuum is that you might have someone who is stabilized. They don't need the acute level of care, but again, they're having difficulty getting into treatment or finding them something in terms of more stable. or the different types, right? I know we had a hearing on inpatient psychiatric facilities, but I think that sort of illuminated, not everybody needs to be in that. Some people need to be in a partial program. Somebody might need a day situation. And so have we done an assessment of what our full continuum looks
Yes.
like for someone who started involuntarily, and what are their options to continue
We
treatment?
know there are two big gaps in our system.
Okay.
Partial hospitalization and inpatient and intensive outpatient. And those are two of the services that we are working to try to develop. We've been working with DHCF in terms of what the billing framework might be so that we have some revenue and some resources to support that. And we are also working with DC Health around, how we might need to do that. Those are two big gaps.
Okay. What's our timeline on some of these? Or I guess our hope, right? Because obviously you don't know who is going to
Yeah.
respond
Right.
on certain things, but I'm just trying to understand what our goals are around timeline of
Yeah.
addressing those
As a
two.
whole, we don't have a defined timeline, but we are looking at that and trying to see what we can get in place as soon as.
Okay. Do we currently have any intensive outpatient program options in the
Um,
district?
I think there's.
For youth,
it's
there's
for
one
youth.
at Georgetown
Mhm.
MedStar.
Right,
Okay. And what about partial hospitalization?
Not for youth.
none.
Okay. What about for adults?
No,
No.
not to my knowledge.
Okay. Intensive outpatient for adults?
No formal program.
None. Okay. All right. Yes, major gap. Major gap, not having any. Okay. Okay, all right. So let's talk about youth inpatient for a minute. As I understand it, DBH expects PIW to maintain 42 adolescent beds, even though the facility typically serves about 5 to 10 youth at a time. The maximum that they've had in the last few years have been 15 at a time. So given this discrepancy, can you explain why DBH expects them to continue at a 42 bed capacity?
Yeah, go ahead.
So you're correct in that the number for POW has been going down for adolescents, but if you look at the data that's presented by Children's Hospital, their numbers are actually going up for you. And so I'm not sure that it's the need necessarily, that there's a decrease in the need of kids who need inpatient hospitalization, but you're accurate that the numbers at PIW have been less.
Okay, so what's, I'm not privy to the children's numbers, but perhaps you are. What are they averaging at this point?
So Children's Hospital in 24 had about 183. And in 23, they had 164. And about 25 to date, which I think includes October, November, and December.
And how many beds do they have?
It's in the teens, I think. I don't want to misquote. We can get that to you.
Oh, yeah, I think it is something like
Like-
12 or something.
Yes,
Okay.
it's in the mid-teens.
PIW in community has a particular reputation, right? And so even if you were to say there are 42 adolescent beds that are available there, I would imagine that a family who went to Children's would be hesitant to transfer their child to PIW, where it is not all pediatric focused, but there are also adults there as well. And so then it begs the question of, we're asking an institution to hold 42 beds, even though they'll never have 42. But they are seeing an increase on their adult side, right? They want to, do some changes over there. And so I'm just trying to understand, is this the best solution? I guess it's our current solution, but it may not be our long-term solution.
Well, I think we're always open to collaborating and making sure that there's appropriate access for our youth. If they need to be and an inpatient unit, of course. I think one of the things that came up at a previous hearing, I think with PIW, is that some of the youth from DYRS are taken to PIW and they receive services there as well.
Right.
And so, again, I think it's always good to have multiple locations who could be providing services for our youth.
Okay. The pre-hearing responses indicate that a significant percentage of youth discharged from inpatient hospitalization do not receive mental health services within 30 days after discharge. What's the reason for this gap in follow-up care?
Sure. Well, in our oversight responses, 83% did receive services within 30 days. And so, again, we would like it to be 100%, right? Connecting our youth to CSAs or if they need SUD services as well. As Dr. Bazaran mentioned before, we highly encourage and try to make sure that youth and families are connected to CSAs, but ultimately it is their decision. So sometimes they're youth who opt to not engage in services. Again, we like that to be a small percentage, if any at all. So.
Yeah. Sort of following up from that, but a little bit different. Dr. Bazaran, you were having this conversation with Councilmember Freeman about this as opposed to, consumer choice, which I think is important. I think on the housing programs, though, when I'm having conversations with neighbors about a particular housing program where they feel like a particular neighbor in that situation who has a permanent supportive housing voucher, right? So you are receiving this voucher because we have determined that you need some additional supports to be able to maintain a stable living environment and situation. And then to say to them, yes, somebody might have a permanent supportive housing voucher, but they don't have to receive any services or participate in any services. They look at me crazy. Because it's like the only reason you're in this housing program is because you need support, but then you don't want to take the support, but you're in the housing program that says that you need it.
Well, remember, the Home First program, the permanent supportive housing program for the district is actually managed by DHS. And someone might be placed in a house, in an apartment or scattered site housing and develop a need for additional mental health services. And I think that that's one of the reasons why we are implementing a grant program, a contract actually, to provide
Intensive
just-in-time
case
services.
management.
This is the one, yes, right.
I wanted to cut it, but you said this was important.
It's important.
Have you awarded it?
It's almost about
It's
to be
awarded.
awarded. Yes, it's
Yes.
awarded.
Have they started?
No, not yet.
No,
That's
but
recent.
it is awarded. Yes.
Okay. Okay. So is there any technical assistance whatsoever that DBH provides DHS with the management of PSH?
Separate from this dedicated program contract that we're just talking about, our other staff, intensive care coordination and other outreach teams do reach out under those circumstances to folks in scattered housing. There are a lot of scattered housing sites and a lot of residents. So it certainly outstrips our ability to meet everyone's needs. That's why we lobbied to get this additional money to to develop and execute a dedicated staff primarily to do that. But yeah, when we're notified of those circumstances and are aware of them, we do all we can to engage and support.
Right. And then also DHS and DBH do collaborate very closely. They do have some of our providers working under contract with them, like Pathways to Housing, like MBI, that have the clinical skills to provide the kinds of supports that are required. In addition, our outreach teams work very closely with them on an ongoing basis.
But I will say, so you know, the public perception is that DBH is supposed to provide the services for permanent supportive housing and DBH is not doing their job. That is the overwhelming perception. Nobody's blaming DHS. They're like, these are individuals who are in need of behavioral health services. We have a Department of Behavioral Health. Why are the services not being provided? And so that's why I'm kind of like, I don't want your name to be besmirched out there. And if it's not your fault, but there's some failure that's kind of happening here. And so, you know, you guys have housing vouchers too, right?
Yes.
Few, yes, we do.
Okay.
We have
We're very- and we're very-
space in 20 Home First this year, for this year. Very small number
Okay.
of new ones.
So the pre-hearing responses mentioned that there was an average wait time between referral and placement for housing of about 4 to 6 weeks.
Yes.
How does someone come to you all for housing versus going through the DHS process?
Okay, different programs. We have, like I submitted the data, about 850 DBH housing voucher slots. I'm sorry, 832.
Okay, so you have 832
Oh.
DBH housing voucher
voucher
slots.
And then another 220 site-based specific slots. And what happens is, again, the priority populations we focus on are people that have been previously or currently admitted to St. Elizabeth's, who have high acute needs, obviously, who are coming out of other hospital, who have long-term care needs, like possibly are being considered for a skilled nursing facility, and we're trying to avoid that placement. So people and a significant mental health history. So all of these folks are engaged and connected to care. We work with a provider to identify, since the need is greater than the capacity, okay, because 90% of these slots are filled approximately right now. We try to identify people in concert with the providers, and then there's a process. They have to do an assessment. They have to submit a referral to DBH. It's a process. So once they make the referral, it takes about 4 to 6 weeks to, which includes an inspection of
Okay.
the facility that they may desire to reside in. So it's a process.
Is it possible that someone who's on your list is also on DHS's list or DCHA's list? Does that make what I'm saying?
Yeah,
So
yeah, it's-
DCHA has their housing, DHS has vouchers.
Yeah.
Possible, yeah, yes.
Um,
But they're coming to us, which, although 4 to 6 weeks is a quicker process usually than the others. And so they see that as a quicker path to get into housing.
well, so how long does someone, if you're able to process for 4 to 6 weeks and you're not full, how long does someone usually stay with your voucher? Or stay in your program rather?
Oh,
90% of the folks that are in our housing stay in our house. At any point in time, we have 90% tenure rate. Okay, people are usually in that level. We have various levels of housing, but in our housing for a long period of time because their needs don't change.
Okay.
Their needs don't change. They don't come out of that housing, usually except for death or, some do, but people are in that program for some time.
Okay, so for your Home First program, are there any service requirements in like, if you were in this program?
Oh,
you were-
absolutely. Contrary to what you said, the Housing First program to DHS, first people have to be working with a CSA to get referred to the program.
Okay,
And then we have a residential support team that engages them and supports them and assesses that they're getting their needs, that their needs are being met. And we are holding the providers accountable to ensure they provide the right support and services to that member, because as you said, it's presumed that they need support in order to be in that housing. So, there've been occasions where people are non-compliant, they don't follow up. We don't kick them out of that housing because they're still mentally ill, and we work with them. But yeah, we expect them to be in service, and we
Right.
make sure that happens.
yeah. And here again, we focus on a priority population,
which,
Yeah.
I mean, Yes,
High
right, someone who
needs
is stepping
people.
down from St. Elizabeth's or in
Or
others.
jail.
Absolutely.
Incarceration.
But I'm wondering if the level of support that you all are providing is more successful than what we are doing in permanent supportive housing. I kind of wish that Councilmember Freeman was still here because he chairs that committee, but I mean, obviously you're dealing with less people than
True,
DHS.
true.
Um,
And more probably severely ill people, consistently chronically severely ill than the typical permanent housing folks. Yeah, but they're getting more support, which is why their needs are being met and they stay in housing pretty successfully.
that's what I was sort of get to from the number standpoint of individuals who enter PSH and are like successfully sticking with it. It's not a high number.
True.
And so that's where I'm asking the questions around, if something is working for you all, are you not sharing that information of, hey, DHS, I hear you're having issues with your program. Try this.
We partner with DHS. They're very familiar with our program and how we operate. And that's how we developed that other program to support their site-based housing. Yeah, so we're working with them to provide as much support on their side in their housing program as possible, given the
Okay.
resources.
Do you guys want to be in the housing business?
What is the question? Do we have what?
We want
wanna be in the housing business.
Oh, do we want to be in the housing?
Everyone behind you shook their heads no in very unison.
Yes.
Okay. All right, let's talk a little bit about the provider network and program quality. So we talked a little bit about some of the issues and gaps that we have on the youth side, so I'm aware of that. When we're talking about some of our community-based provider pieces, how do we assess quality? And by that I mean, you know, yes, you have clinicians, yes, you have slots available, but is someone actually being helped and served through that process, right? Had a gentleman who testified on Monday from he was connected with a particular provider. He had an experience where he was having a moment of crisis and they just called him PD. He didn't go back for a year. Now, obviously we use this provider for other things, but I'm just curious in terms of if you all have, as you do your assessments of your providers, if someone persistently and consistently has like 60% of their slots open, even though you all are making referrals to them, perhaps something is amiss. So how do we assess quality?
I think I responded to that a little earlier in terms of, we do have quality indicators. We do have a provider performance report card, for lack of a better term, that really looks at a variety of quality metrics and where the providers stand up on those. And it's by provider. And when there are instances in which there are issues, we do follow up. Our certification does have very specific requirements. And in addition to that, we do require that they have national certification. And we also are putting in place additional quality indicators for performance based on HEDIS and some other national measures. That's one of the things that we're doing from a policy perspective.
Okay, so you called it a report card.
I mean, I can provide a
Metaphorically,
performance plan. Yeah,
I've got
yeah.
what the charter schools use a tier system. We've got state
Yeah.
report cards on the education side of things. I'm curious, when you are informing a provider of where they or what they received, are they looking at also this is where you are in comparison to your peers?
That's right, because there's a graph that shows where they are. on
Okay,
each
is this public?
indicator.
The graph?
Yes, I mean, it's on the provider performance report. The one for 22 is actually on the website right now. 23 will be there shortly.
Okay, is there a particular reason why we are the
It was a new
year.
process. We started it in 22. You have to go, we went through a process of making sure that our providers understood their data, of working with them around their data, and helping to understand what the quality requirements were. And so
Okay.
we're catching up.
Okay, if you have a provider who is not scoring well, particularly well, is the Access Helpline giving out their information to people who call?
I don't think so.
Can we confirm what that process looks like?
I don't think Access Helpline is saying this one has scored X on a report.
Which is,
No.
no, which is what I am saying. So for instance, if you have a provider who you know who is struggling in terms of quality,
Mhm.
if I had a family who called who was looking for a placement, would you not take that person, the place that is struggling on quality out of rotation momentarily? Can you, or somebody else, I don't know. I'm just trying to, because we have this situation, yes, consumer
I understand.
choice. But if I'm just a family member without knowledge base of, oh, hold on, everybody has their mics on, that's what the feedback is.
Oh,
If I am a family member who's just trying to help my family member get services, how am I supposed to know what's a good spot versus not, as opposed to just looking at, hey, this one is the closest one to me and they're accepting a patient. So that's what I'm trying to say. Like, if the agency has information to suggest that there's a provider that is struggling, why do we continue to offer that up as an option? And just say that, well, the consumer has the choice to figure out whether or not it's good. If you could introduce yourself for the record.
Good evening, afternoon. My name is Atia Jackson. I'm the Senior Deputy Director at the Department of Behavioral Health. The Department of Behavioral Health has a process for suspending referrals to providers that don't meet standards for a variety of reasons. When that provider is on a suspended referral list, that is communicated to the Access Helpline, and we do not refer providers to that agency. There are some providers that even self-place themselves on a suspended referral list when they know that they're getting through a backlog of intake and referral. So there is a process for managing that.
Okay.
We don't tell them what's in there.
Okay. So if someone got to the level of suspension or they're choosing to put themselves on suspension list, then we're taking them out of the queue.
Correct.
But if there is a provider for whom your data metrics are saying, they're not the strongest, we're not going to pull back.
Because like many of the processes, we have to ensure that it matches our policy. And providers can be working on a process to improve that does not quite meet the standards for suspended referral. And as Dr. Bazaran said, the information about the provider performance, our system performance is publicly available. And we can work with within our Office of Consumer and Family Affairs and peers to make sure that information is more visible to the public.
I think that's helpful, right? If I'm looking at a comparatory system of people using consumer choice, which would be around schools, for instance, right? It's public. So you know if a school is tier 3 when you decide to make that a choice. You know that that is not a tier 1 or a tier 2 option, but you're still choosing to do it. And I feel like if we're not putting that information out there, I could see how someone might resent the idea that I call DBH, they gave me the name of these folks, I trusted that everyone that they told me was going to be high quality and good. How was I supposed to know to go look at the performance report to determine whether or not this is a good option for me or for my family? So if we could work on that, that would be great. Okay. In terms of provider fraud, unfortunately, we've had a couple of cases this past year. None so far this year. Knock on wood. But when you all have a suspected detection of potential fraud activity, that's just, you refer immediately to the IG?
We do not refer immediately to the IG. We refer immediately to our partners at Program Integrity at the Department of Healthcare Finance.
Okay, all right, so, okay, we'll follow up with that. So during a roundtable that the committee hosted last October, Deputy Mayor Turnage shared that in FY '23, the district spent 38.7 million on audio-only community support services. Given this, and he sort of alluded that this was a significant increase from prior years. Given this substantial expenditure, what steps are we taking to do quality checks here to ensure? I think of all of the various services that we do, audio only is probably the one that is most susceptible to fraud because they don't have to physically see someone.
We have put policies in place, go ahead, to really put some guardrails around that.
Okay.
Yes. Some of the increase we expected as we were in the pandemic, and we wanted to make sure that services were available via telehealth. Some of those increases have continued despite being out of the pandemic. And as such, the department worked with our partners at DC Healthcare Finance, and we proposed emergency and proposed regulations to limit the amount of audio-only telehealth that can be provided to 6 units in a treatment planning period.
Okay, how long is a treatment planning period?
The treatment planning period is 180 days.
Okay.
And so you're allowed 6 units in 180 days. We also provided a pathway for collateral contacts for telehealth services. So there are times when you're a community support worker or a therapist and you need to reach out via telephone to make connections and referrals with your peers. We continue to have a pathway to do that through the collateral hours contacts, which are separate from audio-only telehealth to a consumer.
Okay. Were there any complaints when you all rolled out this change?
I'm going to be 100%. No, because we had feedback from the Provider Association that they wanted to partner with DBH to limit fraud, waste, and abuse and maintain pathways for telehealth that is appropriate. While I'm sure and there were requests for more hours of telehealth audio only, we met in the middle with maintaining and increasing 20 hours for collateral contacts.
Okay. All right. I'm looking, while you're sitting there, I'm trying to look for the questions that are relevant so that you don't have to come back and forth. Okay. I think we're okay for right now. Oh, wait. Okay, so ACT services. In the pre-hearing response, we saw that you all said that DBH does not track ACT referrals made by CSAs or consumers directly. I'm curious, why not?
I will turn to Dr. Moise to talk about ACT referrals.
Help me understand your context a little bit more clearly, please.
I think we asked a question about ACT referrals. And the response that we got back was that you all don't track them specifically if they've made from a core service agency or from a consumer directly.
The question is about the source of the ACT referral, not whether or not we're tracking. We got a referral and we delivered the referral to a rendering.
The source, who did the referral?
Right.
Yeah.
Yeah.
That's, okay, I was confused. Thank you. She's correct. That's right. We do track ACT referrals because it's our highest level of outpatient care for folks that are community-based outpatient care for severely ill folks. So we're tracking.
But the source,
Right.
you do.
No, I'm not disagreeing with what Atia says. I was trying to give you more context.
Okay.
We don't track who makes a referral to ACT, but once a referral is made, we track those cases very closely is what I was trying to say.
Okay.
We stay with those people and track and monitor the service and care they get, as well as how the providers perform.
Okay. What I guess I'm suggesting is that if you were to track the source, that would provide information around understanding better demand. Like if I don't know, 50% of your ACT referrals are coming from CSAs, that's one thing. If you have like 80% that's coming from the consumer itself, that's not something different.
Well, yeah, ultimately we know, we're not tracking referrals proactively, let's say, to an ACT provider. But because we're tracking the cases, we know where those people are coming from and we know what their level of need is and so forth. And I can tell you, because it's the highest level of outpatient community-based care for mental health, those people are coming from appropriate sources because the alternatives are not numerous in terms of what those people need other than inpatient. They need that level of intensive, collaborative, cross-functional support in order to stay out of the hospital.
Okay. The average time for ACT service authorization to the first paid claim was reported as 13 days in FY24. And then so far for FY25, it's been 8 days. What accounts for this improvement?
We have a dedicated team. I mean, we're really working hard to make sure these folks get the care they need. I mean, we've provided more latitude and choice and in terms of ACT providers to be able to provide care in a more integrated, collaborative way. We've increased the funding and financial support for that service, whereas providers used to be needed to bill in 15-minute increments. We're now giving them a monthly rate and broadening setting expectations for the ACT team in terms of the team accountable for this person and how they need to interface, but giving them a lot of flexibility in terms of how they engage with that consumer because their needs are all different. So I think all of that has allowed providers to be more proactive and responsive.
Okay. I had a lot of colleagues here, so I'm trying to make sure I'm not asking the same question twice. Let me ask about school-based mental behavioral health program, though. Now, it's school-based behavioral health. So Dr. Bazran, I've been chair of this committee. This is my third year. This is my third year asking about this rate study. And for the third year, you all say the results are not available due to missing CBO data. What is missing from our CBOs?
Oh. I think I heard part of your response. You asked for why?
We've asked for the results from the rate study.
Oh, yeah.
And for 3 years, you guys have said that the rate study can't be completed because you don't have what you need from CBOs. And so
Well, actually, the rate study regarding the school-based behavioral health program implementation analysis, which is what it's called, due to kind of the budget implications, the mayor's budget team is currently reviewing it. And once addressed, the report will be released. That's where we are right now. It's gone up to EOM.
I'm laughing because I had breakfast this morning with the city administrator. And we talked about how oftentimes people will say it's with EOM for review, but it's like in the ether. So who should I talk to directly? Should I talk to the mayor's budget director? Should I talk to the city administrator? Who has it? Is it with the legal team? Is it, where in the cog of the system might we find this particular study?
Well, I think that it is going through that budget and policy development process. And so I guess you could talk to the CA. You talked to him earlier today, you said.
Okay. Okay. Will it be released in time for the budget?
You could talk to the CA, who will determine it. That's not, my determination.
Are we contemplating major changes to the school-based behavioral health program? Only 57% of schools have a person.
Well, I think, as you mentioned, 57%, we've been sitting here. I know I've been here for a few years. You've been here for a few years. And so we've tried lots of different things this past school year, taking suggestions from both coordinating council, some of our sister agencies. We've tried 2 pilots this year. We've also tried some innovative strategies. And so I think, from our perspective, we are very much dedicated to providing school behavioral health services, but what we do know is that we're consistently not getting to where we want to get. And so that road path, we need to shift. And so
Right. That's why I'm asking.
Yeah.
I don't want to keep doing the same thing over and getting the same result. And I appreciate the
Right.
creativity and your willingness, Dr. Bazran, to try different things, right?
Mhm.
We've heard positive responses from the charter LEAs who are part of that pilot. And otherwise, there were quite a few LEA leaders who testified during the hearing.
That's
And
right.
I think for some of them, they're like, I don't want a trainee. I want somebody, I don't want a trainee on my kids. I want somebody who is staffed and who can understand the cultural competency of my student population and otherwise, which I totally understand. But it is also like, we use this as like a flashpoint. And I think you even said it in your testimony, right? We have the funding to make sure that every person has one.
Mhm.
Great. But we are not delivering. So then it's like, okay, how can we retool this program to make it more effective to reaching our goal as opposed to just the arbitrary of one for every school who wants to participate in the process?
And I really do think that's why we need the data on how many resources are in each school so we can see where there's a gap and we can direct the resources there. It may mean, moving people around. It may mean using additional strategies which we have not used, like telehealth. Because we do have to do, and we are looking at what other kinds of strategies we might use to provide services to our kids.
Okay, I think the formulation, and we've talked about this before in terms of how we pay for this, is not coming to fruition of what we thought was going to happen. So for instance, the Medicaid billing for school-based behavioral health clinicians in last year was less than $500,000. And so, there are a variety of different things there. I think we heard testimony where parents are sometimes confused of when does the payment come in versus not, and not wanting necessarily a surprise bill. Especially if someone doesn't have Medicaid, like what do you do? How do you bill for that? All of these different things. And so I hope that we can work together to fix this program and do whatever to make it just work better. So that's continuously sort of in the same vein of where we are. I want to give a shout out to your Healthy Futures team. I think that was like the most positive testimonies that we received, which is from the Healthy Futures team. And as I said during the hearing on Monday, I think early intervention is so key and so important. And so the work that team is doing to support these early childcare centers and ensure that, for some of these our littlest young people who are having these behaviors, to help both not just their educators, but also the parents, I think is hugely, hugely successful. How many people do you have work on the Healthy Futures?
We have 17 consultants, and then we have 2 treatment clinicians that were part of the pilot. So 19. We currently have 1 vacancy, so pretty well staffed.
Okay.
And then we have 3 supervisors and a program manager.
Well, you referred to it as a pilot.
No, sorry,
Okay.
the treatment component was a pilot that we started through ARPA dollars.
Okay.
And we have since, those folks are now in local FTEs. And so we're continuing and we plan to continue. So it's not a pilot anymore. We're
Okay.
providing treatment services in those 8 centers.
Okay, that's good to hear. Just a lot of issues, a lot of things that have been brought up. As we're sort of winding down here, there are a couple of things I need to ask. So there was a field test that was conducted by the Office of Human Rights to see whether various agencies would provide interpretation services when they called. During the field test, now this wasn't just for DBH, this was for, again, across the government. During the field test, there were 3 testers who called St. Elizabeth's and requested interpretation services, and none of their 3 testers received it. So it begs the question around language access. I wanted to make you all aware. Are you aware of
Yes,
what OHR did, and then how are we addressing that?
we're aware of it and provided additional training for the staff so that they know how to use the language line. We made sure materials were translated into the languages that are needed so that we could address that and how to, so that we make sure that we have remediated that issue.
Okay, and then in terms of if someone needs sign language interpretation?
Yeah, we have sign line interpretation available.
Okay. Councilmember Freeman, we were on our way to winding down. If you have a couple of burning questions of desire?
My ears were burning because I heard that you said at some juncture, oh, I wish Councilmember Fruman were here to hear this. I actually got 3 emails to that effect, and so I thought I would, many eyes, but we can talk about it afterwards. I'm not trying to keep people from their dinner or from me from doing something, but I thought I would circle back if you were still going to hear whatever it was that you thought.
We're talking about their housing services and the programs they provide in the housing space in comparison to the work that they do or that DHS does.
Yeah, and that is why I was focused on the assessment tool up front, because you have different places that folks go and there's different levels of services in different settings. And so I'd been asking about, okay, how do you make the assessment of which is the most appropriate one? But I really don't want to slow the completion. You've been there for a long time. Thank you very much for your testimony, for your work, and thank you, Chairperson Henderson.
But I will say, as we sort of noted, the issues and concerns around individuals who are supposed to be receiving services in housing because they have been determined that to need that additional support to be successful in housing is something that I hope that we all can work together to improve.
100%. Thank you.
Thank you. Dr. Bazaran, as we wrap up here, I want to ask, so interestingly, I was looking through the pre-hearing responses and we asked what are the top 5 crises that are addressed or issues that come up with the CRT team. And you know what's in there that we don't often talk about? Hoarding. And we had a witness who was incredibly persistent. In fact, I talk about hoarding a lot with Chief Donnelly from FIMS because he has a whole, it makes things incredibly difficult for their folks if there is a fire or some type of emergency that arises. And so, are there providers in our network who specialize in this? I don't even know who we would call. But I do know that just referring folks to the Department of Aging is not sufficient.
It's really a very complex mental health disorder that does require people with specialized services to provide the services that are needed. And I think it's something that we really need to work to address more effectively.
Okay.
Mhm.
Are there other jurisdictions who do this better?
When I was in Maryland, we actually did have a group that focused on hoarding and hoarding behavior and had some specialization in that area.
Okay. All right. That's an area I think for us to sort of look at further. All right. I think we covered a lot of issues and obviously I could keep going. We'll talk about Department of Corrections and all of those various things, but we have some follow-ups for you all that we'll definitely communicate on. I want to thank you and your team for your testimony, for being here today and for the information that you all have provided. Now, for the public who is watching, this hearing was for DBH government witnesses, but if anyone wanted to submit written testimony who were unable to join us on Monday, you can do so. The record will remain open until 5 p.m. on Wednesday, February 19th. You could submit your testimony electronically via the council's hearing management system at dccouncil.gov/hearings. The next performance oversight hearing for this committee will be for the Deputy Mayor for Health and Human Services, as well as the Department of Healthcare Finance. That will be next Wednesday, February 12th at 9:30. Our time right now is 5:50 and this hearing is adjourned. Thank you so much.
Thank you.